Adebayo Samuel Edunjobi. I'm a specialist rheumatologist. I had masters in public health and health service administration. And I was working as a senior research coordinator at this clinic when this study was done. And I would say it was out of curiosity, and the goal of the clinic then was to get current treatment of hepatitis C. And they are working in conjunction with the Project ECHO platform of the University of New Mexico. So that's where we were then. And the reason for Farmington is like 3 to 4 hours away from Santa Fe, where the clinic was situated in New Mexico. But most of the patients that presented with these symptoms were from that area. So we thought we should just invade the area to find out what's going on. And we have a patient that walked in, coincidentally, that said he was done with drug and alcohol and needed help. And coincidentally, it came from Farmington. So it was our lead to Farmington. That's how the study started. And that's what informed the choice of the location. So we got most of our patients from Farmington and from our database in the clinic. So this happened during the COVID era. So we had our challenges, but we were able to navigate it. So the essence of the study then was to create awareness of the rising trend of substance abuse. And it's also to show result of liver injury and the link to rising trend of hepatitis C viral infection. It's like killing a bird with 2 stones. Okay, that's just my preamble. So talking about the background, patients engaged in substance abuse are prone to getting infected with hepatitis C virus. And this is a study that's been done regionally and nationally as we move on. And this is very common in excessive illicit drug use. And with heavy consumption of alcohol associated with the drug use, the liver becomes more vulnerable, causing more severe liver injury, promoting disease progression to cirrhosis, and increasing the risk of liver cancer. So it's like a progression from one stage to the other. So like I said, the main primary objective was to, like the topic said, to review the implication of drug use as linked to liver injury and the rising trend of HCV. While the secondary objective was to create awareness of the prevailing and persistent surge in substance use in that environment, and also to show the consequences of that on especially the liver. So the intuition that the case has been on steady increase over the last few years was informed by the conduct of our study, which was extrapolated with existing studies. Like I said, there have been studies done regionally and nationally that supported our study, which we didn't even foresee until we started the study. So it was a cross-sectional analysis of individuals that qualified based on our method as being drug and alcohol dependent, were excessive consumer using our set parameters with evidence of sequelae. The evidence of sequelae now talks about liver injury, like I mentioned. So it was done over 6 months between July and December 2021. We got informed consent through flyers. We couldn't really access the community. Like I said, it's 3 to 4 hours. And because of restrictions of COVID then, we had to apply other means of getting across to them. So initially we have 65 people that showed interest. Eventually we recruited 54. So we collected data through direct interviews, telephonic, and through self-administered questionnaires. And of course, like I said, we have a database where we got other information too. So abuse of alcohol based on our parameters refer to either heavy drinking when taking too much or too often. So we are talking about the quantity and the frequency, taking too much or too often. And when you talk about heavy or significant drinking, this refers to 4 drinks or more in a day, or 15 drinks or more in a week in men, or 3 drinks or more in a day, or 8 drinks or more in a week in women. And this is just what you find down. 1 drink equals what you have highlighted down there. And it should be said here that in some instances, because of idiosyncrasies, a single binge of alcohol drink will also lead to liver damage. So it's not in all instances that you have to take 4 drinks or 3 drinks before you have liver damage. So the issue of idiosyncrasy is also coming. So on the results, we have 54 people participating in the study across all race and ethnic groups. And the age range was between 18 and 70. And I would say expectedly, because males are more active, we have a predominance of male engaged in substance abuse, and consequently tested positive more for HCV, and then more prone to liver damage, as against the 29.6% with reduced susceptibility to the sequelae in female. Talking about racial distribution, because we have a predominance of Hispanic and Latinos in New Mexico, and especially in that area. So we have more of Hispanic and Latinos involved. That may explain that, followed by white and non-Hispanic. And this is what the table is showing. 38 males against 16 females, with a total of 54. And the age range, like I said, and the duration of drug use or alcohol use before presentation was between 2 to 10 years in males, whereas it's between 1 to 6 years in females. And about HCV seropositivity amongst them, like I said, expectedly, because more males are involved, more males are also down with hepatitis C viral infection, as recorded in the table. And still on the result, alcohol beverages commonly implicated in liver damage in these studies are more of distilled spirits, which comprise vodka, whiskey, rum, brandy, and gin, followed by regular beer, or sometimes the other way around. And of course, I've mentioned this before. Whereas common illicit drug studies are cocaine, morphine, heroin, meth, amphetamines, and marijuana. It's also common in that environment. Fentanyl and the opioids are very prominent use in that environment too. And it should be said here that illicit drugs users are known to constitute the core of hepatitis C epidemic, apart from other causes. Okay, so this is just what I just explained. Types of illicit drugs used. We have, for male, more of cocaine to marijuana, to heroin, then fentanyl, oxycodone, methadone. Whereas in female, we have predominance of marijuana, followed by cocaine, heroin, and morphine. And on alcohol, like I said, it rotates between beer and the distilled spirits in male, and more of beer in female. Then we have the mixed alcoholic beverages, followed in females. Then talking about the reasons for substance use in that environment, it was found out that for both male and female, the reason why most of them use substance abuse is due to peer pressure, followed by the issue of homelessness, as recorded in this table. So the rise in excessive drug and alcohol use in the US is fast occurring, ubiquitous, and epidemic nature. This is one of the recent articles I put on my LinkedIn page. So this is just something I lifted too. So there's an argument that the legalization of marijuana as both medicinal and recreational drug by many states in the US and still counting as further emboldening abusers to indulge more in the use of these illicit drugs. So, of course, the consequence is the insidious and stealthy assault on important organs in the body, and we're dealing with the liver here. Like I said, liver injury, which promotes to progression to cirrhosis and increased risk of liver cancer. And research has shown that almost a third of individuals with substance abuse with clinical symptoms of liver disease have been infected with hepatitis C virus. Once there's liver damage, there's every likelihood that the individual is positive for HCV. And this is 4 times the rate of the infection found in others without liver damage. So, unexpectedly, people with more severe liver disease are more likely to test positive for the HCV infection. So several studies have indicated that heavy consumption of alcohol, I mean, we mentioned different types of alcohol implicated before now, but this is also telling us that it's not just about the quantity, but that heavy consumption matters too, rather than the types of consumed alcohol or illicit drugs used. And these are what accelerates the progression of chronic HCV to cirrhosis and liver cancer in affected individuals. Well, in conclusion, it's the first one. There are documented evidences that the HCV infection is on the rise among substance abusers and may continue to be on the rise in the coming years. And this findings strongly corroborates Hera's submission that illicit drug users, regardless of age, gender, or race, are prone to HCV infection, especially when it is used in prolonged and injudicious use. So this is in line with the national survey conducted in 2018 and published in a 2018 edition of the American Journal of Public Health. And their submission was that the national increase in acute HCV infection is related to countries' opioid epidemic and associated with IDU. So we can see from this graph that in 2004, it was just like 750 cases. And within a few years to 2014, that's a space of 10 years, it has risen far above 2,000 cases. So it is something that is very significant. So there are lots of intervention, and there are lots of currently availability of FDA-approved antiviral medications for HCV. Amongst them, like I said, are the ones we work in collaboration with the Project ECHO of the UNM. And well, I might not need to go into details of the medication. Well, most of them are direct antiviral agents. Epclusa is what they use anyway, majorly at UNM. So most have as high as 90% of success rate when taken within short periods of as little as 3 months and can potentially cure HCV. There's a newer one, Mavret, which can be used within 8 weeks in ages 12 years and above and has the same potential of cure. So since associated morbidity and mortality are likely to be reduced in the face of early diagnosis and treatment in affected individuals, it is therefore essential that measures be put in place to curtail this ugly trend. So, and this is by ensuring that adequate steps are taken towards effective treatment and rehabilitation. So this will be all I have to summarize. There are lots more to say, but because of time, I'll just say thank you so much for listening.
This talk may be a little different from some of the other ones because I'm presenting the material in my book, which is based on Dale Bredeson's work at the Buck Institute. So it's not so much of an abstract from research, but more like some of the key materials that really all of us can use and immediately apply for our patients. And my book is available on Amazon, called Regenerate Your Brain, A Breakthrough Plan to Restore Your Brilliant Mind. Okay. Basically, you know, everything that we learn from present time. So this is just an encouragement for us to bring our consciousness to the here and now, which is part of presenteeism and allows for us to grasp the information. And these are, this is a way in which you can do that, where you just feel your feet on the floor and your spine supported by the chair and feel yourself present at this moment. So I'm going to be talking about the MIND diet, which really came from Dale Bredesen, hyperbaric oxygen therapy to heal the brain, and cranial osteopathy for fluid flow. And this is what's called the Wheel of Wellness. These are the 8 sections of health. My background is in integrative medicine. I'm board certified in integrative medicine, and I've been practicing for over 25 years based on this Wheel of Wellness. So we're going to look at a couple aspects of each one of those. The MIND diet was established in 2015 at the Buck Institute of Aging. And it first was applied to 10 patients. 9 out of those 10 had a diminishment in their memory loss. And it's based on eliminating all simple carbohydrates, gluten, and processed foods from the diet, as well as, so essentially avoiding the 4 damaging foods, being the whites, white sugar, white flour, the blacks being charcoaled meats, the fakes being hydrogenated oils rather than butter or olive oil or coconut oil, and alcohol in excess. And there's 15 dietary components that can powerfully impact our brain functioning. Many of those are actually vegetables, green leafy vegetables, and also nuts, berries, beans, whole grains, fish, poultry, olive oil, and wine in moderation. But the MIND diet is more than just food. So it also involves meditation and yoga up to twice a day for diminishing stress. Fasting, intermittent fasting is pretty incredible what it can accomplish. And so that's a window of a minimum of 12 hours of not eating, but that window can also extend to 14 hours or even 16 hours. Sleeping 7 to 8 hours a night, and exercising a minimum of 30 minutes for 4 to 6 times a day. So the brain is actually 60% fat, and the cell membranes are made up of phospholipids, acting as an outer hub for the receptor sites. 97% of the fat in the brain is DHA, which is not made in the body. So the only way we get DHA is through eating cold water fish, about 5 servings a week. For some of us, that can be hard to do. And sometimes it's even hard to get cold water fish that doesn't have a lot of toxicity in it. So there's been at least 3 studies linking healthy levels of essential fats with reduction in anxiety, depression, and improvement of cognition. And I like to measure that in the blood of my patients. I look at what's called their omega-3 to omega-6 fatty acid level, and I look for it to be 7% or higher. And so generally, anywhere from 2 to 4 grams of EPA and DHA, which is how it comes in America, usually comes as a combination of EPA and DHA, is what can really help reduce mood disorders and improve cognition in a matter of 2 weeks, which is really profound, and it can reduce it by up to 50%. So healthy fats, fish oil. What if I told you that they did a study in Japan, Greece, Sweden, and Spain looking at the health of 80,000 octogenarians, or people in their 80s, and they looked at what was it that they were eating that was all in common, and it's actually beans. So 2 tablespoons a day of beans decrease the risk of dementia by 10%. The cruciferous vegetables are also excellent: broccoli, cauliflower, Brussels sprouts, kale. And now going to the leaky gut brain axis. So the blood-brain barrier and the gut lining have one thing in common, and that is that they are only one cell layer thick. Many people don't realize that. So the intestinal epithelium has this one single layer, and that is going to allow for what's called leaky gut, which is where certain things can create inflammation. That's produced by zonulin, which can be from certain foods that create that, or infections. And then once there's zonulin in the system, that can go up to the brain and create a leaky brain axis. So a study published in Lancet, which is a very prestigious journal in England, actually showed that subjects with inflammatory bowel disease developed white matter lesions in the brain, as identified by an MRI, with almost the same frequency as people with multiple sclerosis, which is a disease of myelin destruction. So in this study, 42% of patients with Crohn's disease and 46% of patients with ulcerative colitis had white matter lesions in the brain. So our gut and what we're eating, and if there's inflammation in our gut, has a big effect on the brain. And in my patients, I like to measure their zonulin levels, either through stool or through blood. But if you're not able to get labs that will do that, then you can simply do what's called an allergy elimination diet and eliminate the top allergenic foods, as well as promoting things like fish oil, which can help reduce leaky gut, along with some other things. So there's also this link with panic disorder, PTSD, general anxiety, and depression in those with irritable bowel syndrome. So what are the causes of leaky gut? Alcohol, gluten, casein, processed foods with food coloring, preservatives, excess sugar, and food allergies, certain medications like antibiotics, steroids, antacids, and also infections such as H. pylori, bacterial overgrowth, yeast overgrowth, intestinal virus, or parasitic infection. There can be stress hormones can also cause leaky gut, as well as traumatic brain injury, stroke, and glyphosate, which is what GMO is in certain foods. The top ones would be corn and soy. So glyphosate, which is in certain foods produced by the agricultural industrial complex, will block the shikimate pathway, which is necessary for plants to make certain amino acids, which we need to make our brain chemistry like serotonin. So these are the top GMO crops: corn, soy, cottonseed, papaya, rice, rapeseed or canola, potatoes, tomatoes, dairy products, and peas. So in the ideal world, you would get those non-GMO so that you don't get that irritation in the intestinal microbiome and in the intestinal lining. So probiotics, let's talk about the microbiome for a little bit. So a healthy microbiome is going to nourish the intestinal cell walls, help digestive motility, create brain-derived nerve factor, which can cross the blood-brain barrier and facilitate the production of brand new nerve cells. And these are the things that can affect our gut microbiome. So our genetics, our bile acid pool, the amount of fiber we have in our diet is very important. Ideally, you should have 25 grams of fiber a day. Additives, toxins, phytochemicals, amino acids, and dietary vitamins. And the gut has its very own neurotransmitters. In fact, every class of neurotransmitter found in your brain is also found in your gut. Serotonin, 95% of serotonin resides in your gut. And the intestinal microbiome is closely linked to the enteric nervous system with bidirectional communication through the vagus nerve. So the vagus nerve, which comes out of just back behind the ear, comes out of the foramen magnum and controls our peristalsis, our respiratory rate, our heart rate, gut motility, and can have a bidirectional communication that affects our stress and our mood. So there's another link. And they've actually linked the different types of gut bacteria with our brain's memory function. And we've even seen certain bacteria that are patented that actually change brain MRIs. And that's a particular brand called Microbiome. It's beyond the scope of today's talk. But you could look up Microbiome, that company. They've done a lot of research on the gut bacteria and effects on it, on the brain and on mood, as well as sleep. So the basic plan to create gut healing is sometimes to give hydrochloric acid. If there's not enough acid production, then we can't activate the digestive enzymes. And looking at the stool for the microbiome balance and giving a probiotic. Also fermented foods such as yogurt, sauerkraut, or kimchi will have those probiotics naturally. Cooling the brain inflammation. Inflammation is involved in several disease processes: atherosclerosis, diabetes, cancer, arthritis, Alzheimer's, and traumatic brain injury. And Dow proteins. I wanted to talk about Dow proteins, which is what they find in dementia in the brain. And so they stabilize microtubules. They're abundant in axons and to a lesser extent in the oligodendrocytes and astrocytes of the brain. But those get cleaved in dementia and traumatic brain injury and create neurofibrillatory tangles. And so they are used as a serum marker for brain injury. That's something that I also assess for by doing blood work. I want to talk a little bit about the immune system in the brain because it's different than the immune system in the rest of the body. So the microglia are in the immune system of the brain, and when they switch on, they tend to stay on. And inflammation can stay on for actually quite a long time after traumatic brain injury, 5 to 10 to even 15 years afterwards. It can slow mental processing. Cellular enzymes can get derailed, and there can be apoptosis that occurs as a result of brain inflammation. Brain inflammation can be affected in part by our diets, sugar, charcoal meats, alcohol, also common nutritional deficiencies, and then the direct physical trauma to the brain, as well as injury to other parts of the body. Imbalances in the gut functioning, chronic or hidden infections, not getting enough sleep or stress, as well as toxins like mercury and pesticides. As an osteopathic physician, one of the things, the tenets of our principles of healing is that the rule of the artery is supreme. So circulation, circulation, circulation. The artery brings oxygenated blood. The venous circulation helps drain. And so this is a view of the inside of the brain with the meninges on the top, the dural meninges on the top, called the falx cerebri. This is where the optic chiasm would be with your eyes, and then down below. And why am I showing this image? Because when we think of the brain, we think of the actual cortex and cerebellum, but we don't usually think of the meninges. And these are things that can be torn, micro tears during a whiplash injury or traumatic brain injury, and then the circulation is impaired. So this is showing meningeal tears in 49% of minor or mild traumatic brain injury, such as let's say, falling off your bicycle or even a car whiplash sometimes can do this. So here's the meningeal enhancement And then there can be a smaller percentage of venous outflow through the jugular vein as a result of that injury. And this shows that inflammation and white matter degeneration can persist for years after a single traumatic brain injury. This is showing you the cerebral spinal fluid flow and how important that is to cleaning out the debris that can gather in the brain from a traumatic brain injury. And then this is showing you the normal function versus the buildup. Structural and functional features of the central nervous system. So this is the glymphatic system, which, I certainly didn't learn when I was in medical school. It really came about 10 years ago that we made this discovery. And malfunction of this glymphatic system has been considered one of the root causes of neurodegenerative conditions. So we want to take this into assessment in anybody who's had a traumatic brain injury. 90% of people with traumatic brain injury show signs of autonomic dysfunction during the first week after the injury, but about 1/3 have longer lasting autonomic dysfunction, which would mean beyond 6 months past the concussion. So I ask all my patients if they've had a concussion. Cranial osteopathic manual therapy is a form of therapy that osteopathic physicians do, and some physical therapists do also. That's really designed to accentuate the rhythm of the cerebral spinal fluid flow through the body and reduce plaque buildup, amyloid and tau protein buildup. Other things that help reduce inflammation in the brain are certain spices, turmeric or curcumin, ginger and rosemary. Connection is very important. We know that isolation is as bad, if not worse for you than smoking 2 packs of cigarettes a day. So being in community and connection, eating real healthy, hormone-free, pesticide-free foods, eliminating food allergies, exercising regularly, finding a good osteopathic physician who can do that cranial, getting adequate sleep, and healing emotional trauma. And detoxification is very important. We have 85,000 chemicals on the federal inventory already, for which 75% of the information is not publicly available. And this is based on a lot of actually indoor cleaning products. So, and then I want to talk about hormones. So hormones need to be able to bind to the receptor sites, thyroid, insulin, leptin, for example, but those cell membranes can get clogged by heavy metals and toxins. So mercury is one of the worst, and it can lead to overproduction of reactive oxygen species and impairs ATP production by mitochondria, which in the end is what's going to make us feel tired. So mercury also damages the tight junctions of the intestinal wall. It causes vascular endothelial dysfunction and reduces blood flow. And I test blood levels of mercury and lead in all my patients because we are finding it sometimes in the water or if they eat a lot of fish, unfortunately, because our oceans are polluted. So it's important to take a look at that. And there are courses in chelation for heavy metals. But these are some of the things that mercury or lead toxicity can cause. There can be more subtle findings. I'm going to go through, So we want to identify toxins in our home, avoiding sometimes personal care products that could have toxins in them. You can do lab work to detect the toxins. And then strategies for detox would involve alpha lipoic acid, bioactive whey protein, chelating agents, glutathione, amino acids, and there are lots of herbal support for detoxification. And we want to make sure that the liver detoxification pathways are supported with folic acid, B12, and B6. And you can sometimes eat sulfur-rich foods like broccoli, collards, kale, daikon, radish, garlic, onion, and omega-3 eggs. I want to talk a little bit about sauna because it's an incredible way to detoxify. It also stimulates brain-derived nerve factor as well as glutathione. And it helps take those toxins out of the fat, which is where a lot of the toxins are stored. So these are the things that they have found in sweat that come out from sauna: DDT, DDE, endorin, perfluorinated compounds, endosulfan, and BPA. So they did a study in Finland on over 2,000 men whose ages ranged from 42 to 60 that were followed for 20 years to look at their risk of developing dementia or Alzheimer's. And they showed that taking a sauna once a week lowered the risk by 22%. And taking a sauna 4 to 7 times a week lowered their risk by 75%, which is pretty incredible. So you do want to have adequate electrolyte and mineral replacement before going into the sauna, and optimize your elimination routes. And ideally doing it for 30 minutes a day for 6 weeks initially can get rid of many symptoms. Boosting the mitochondria is important because the mitochondria produce ATP, which runs every single reaction in our body. And the highest number of mitochondria are actually in our muscles, so our skeletal muscles. So increasing lean muscle mass and is going to help with energy production from the mitochondria. So there are many things that are stressful on the health of the DNA of our mitochondria, being mostly environmental toxins and oxidative stress. So aging is one factor because we lose half of our mitochondria from age 20 to 40 and another quarter from age 40 to 70. But there are a few things through the process of hormesis that can slow down the loss of mitochondria. One of them I've already mentioned is intermittent fasting. And another one is temperature differences such as sauna, cold plunge. And then there's also some nutraceuticals, coenzyme Q10, as well as alpha-lipoic acid, have really helped lower the markers of oxidative stress against mitochondrial disease. These are foods that are particularly good for the mitochondria: almonds and arugula, avocado, beef, blackberries, blueberries, bok choy, broccoli, Brussels sprouts, buffalo, cabbage, and cauliflower. And extra virgin olive oil, kohlrabi, mustard and turnip greens, pomegranate, raspberries, spinach, strawberries, turmeric, virgin coconut oil, watercress, and salmon. There has been some research showing that even just 7 minutes of exercise can raise brain-derived nerve factor. So exercise is extremely important. You can reduce Alzheimer's by up to 50% just by doing exercise for up to 150 minutes a week. And high-intensity interval training provides many of the fitness benefits of prolonged endurance training, but in much less time. So you want to, there are now smartphone apps that if you download 7-minute exercise, it'll tell you exactly what those are. But there are things like squats and jumping jacks and push-ups. And then also there's good old-fashioned walking and just basic physical activity. Hyperbaric oxygen, I'm going to go into this next. So we can go days without water, weeks without food, but only 4 minutes without oxygen. So we need that oxygen more than anything else. And oxygen is actually a form of gene therapy. It activates up to 40% of I'm just going to move this, of the proteins coding the genes in our DNA. What our air has is 20% oxygen. What you're getting in hyperbaric chamber is 100% medical grade oxygen. And that's going to translate into up to 20 times more oxygen in your body when under pressure. And this is a figure of a rabbit after 20 sessions of 100% oxygen with no pressure. And this is 100% oxygen with pressure of 2.4 atmospheres. You can see brand new angiogenesis occurring. And there's nothing else on the planet that will do that. So hyperbaric oxygen is a remedy for the toxic effects of impaired circulation.
Dr. Chen, sorry for the
Yes.
interruption. Just about the time,
Okay.
if you can, yeah.
Wrap up. Okay, great. So hyperbaric oxygen can help generate stem cells and really help with the healing. And I'm going to kind of go through this. So this is just in summary: diet, exercise, brain exercises, hyperbaric oxygen. And I'm just going to go through. Tiny sleep is very important because our brain actually shrinks 60%. Cerebral spinal fluid goes around and helps with the diminishment of diseases. These are all diseases linked with lack of sleep, heart attack, coronary disease, asthma, COPD. Okay. And building new neural pathways, essentially through meditation and stress reduction. So I'm just going to zip to the very end. So I just want to thank you. Once again, I'll just go to the very, 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 very end. Okay, yeah. And if you have any questions, you
to speak in this prestigious edition of International Webinar on Healthcare. I'm a doctor with hospital management experience, working as Chief Medical Officer at Lilavati. I have published a book on strategic management of modern hospitals, and I have published an article on AI and robotics in futuristic hospitals. This is my subject interest. So I will move on. So we are going to talk on strategic management of modern hospitals first, AI and robotics, and application of artificial intelligence and machine learning, the second half. See, messy galleries, oily painted walls, stained bathrooms, inefficient staff, dim light and noise. This is how we identify a typical, not only the diagnosis, but in the treatment of highly sophisticated gene therapies, giving targeted treatments to deadly diseases and improving healthcare, and the time spent in hospitals for recovery. The strategic management process at hospitals depends on how efficiently we apply a mix of product, visit-based system and point-based system. The traditional hospital is witnessing an unprecedented change. Robotic process automation, artificial intelligence, digital supply chain, Internet of Things, where machines will be taking over, talking to other machines, and 3D printing for surgeries are happening across the country. Transparency is key to talent management. The organization with clear-cut statement on performance goals and will be the hospitals of the future to perform better than hospital organization with performance goals. Nurturing multiple talents and to develop and identify potential individuals at different levels of nursing. For example, for future we're going to have specialty nursing. We're going to have specialty hospitals like onco care and other care, and to provide them training. The hospitals need to provide them opportunities for training. Now we will go to the next thing, robotic. See how the technology has completely transformed the healthcare sector. I'll have a few slides on robo-assisted surgery. This is an exciting time as surgeons can now perform new and complex procedures with ease. This is applicable in specialties. Most of the specialties I've mentioned, spinal, orthopedic, cranial, uro, general surgery. And the world is moving towards robotic surgeries and daycare. reducing the length of stay in the hospital, leveraging technology with better utilization of resources, help the hospitals in achieving cost effectiveness. Robotic surgeries enables doctors to execute various surgeries with precision and flexibility. How? The machine integrates advanced technology with the experienced skilled surgeon, which provides them 10 degrees magnified high definition view of the body's intricate anatomy. The surgeon then makes use of the controls in the console to use special surgical instruments that are smaller, more maneuverable, flexible than a normal human hand. That the robot replicates the surgeon's hand movements while minimizing tremors, thus allowing the surgeon to operate with enhanced precision, control, and dexterity, even the complex procedures. As the RAS offers minimally invasive surgery, smaller scars, lesser hospital stays, lesser blood loss, lesser complications, faster recovery of patients, and enhances experience for both the surgeons and the patients, and rapidly gaining momentum in the healthcare space. RAS not only can play an important role in training young medical professionals to become more efficient surgeons, but will also enhance the hospital infrastructure in Tier 2 and Tier 3 hospitals. I mean, Tier 2 and Tier 3 cities, nowadays we have a lot of specialty hospitals, and many of them are using orthopedic robots, soft tissue robots. With further progress in AI, machine learning, and data analytics and medical devices, doctors are able to gather insights into patient records and personalized medicine. Advances in telemedicine implemented across the country and used in remote villages, and expertise of doctors miles away can be used. Competency models are being used in organizations. We have used IT solutions like cloud computing, virtual intelligence, artificial intelligence, data mining. Proper incorporations of modern IT solutions into healthcare can be found to be a positive impact on the quality of care. This is an investment that cuts down the redundant, unnecessary tasks and allows the caregivers to focus on meaningful tasks. Technology can be seen as a potential solution to efficient problems in modern hospitals. For example, two-way video notification, virtual video consultations, multi-language video, high-definition video cameras make it easy to connect to patients. The COVID has accelerated the implementation of technology. Predictability and rationality. This slide I will just sum up. The hospital is a complex organization driven by ambiguous and multiple objectives. Actions and decisions come out of interpretive, political, and symbolic aspects more than rationalism. So it is a highly pluralistic concept that makes a hospital difficult to manage. In addition to complexities of the internal, there are various stakeholders. So we have to the management has to strike a right balance between the managerial models and the institutional models, and should act as a mediator. The CEO or the head needs to act as a mediator and face various challenges. The hospital of the future. What is the hospital of the future? Nurturing multiple talents, we already seen. Specialty nursing, leadership competency models, incorporation of IT solutions, application of technology, virtual consultations, video, we already seen this. The future of the hospitals, depending on the level of the engagement of the employees, the ownership, each employee is supposed to take ownership of this particular department. The right engagement strategies, proper environment would make sure the employees contributed the 100% on care delivery, which will in turn improve the efficiency of care. Thank you to all my friends, and hope thanks for the patient hearing. And
of Hang Tuah University. Slide. These are my scientific work. Slide. And these are the award I received. So, next. The background to why I conducted this research, because the success of dental implants is determined by the osseointegration process. And many studies state that smoking cigarette can inhibit osseointegration. But the inhibition mechanism is still unclear. Objective: to identify and analyze the effect of nicotine on the inhibition of dental implant osseointegration through nicotinic acetylcholine receptor, nuclear factor of activated T cells cytoplasmic 1, osteoblast, and osteoclast number. Slide. Dental implant are the good standard for the replacement of missing teeth. One of the most important factors for success dental implant is osseointegration. The osseointegration depends on the osteoblastic activity enhancement around the implants that promotes direct union between the implant and the bone. Right? The success rate of osseointegration depends on oral hygiene, operator skills, implant material used, bone quality and quantity, occlusal load, lack of medical condition, and personal habits such as smoking. This is a part of a dental implant. A is a body implant or implant fixture, and B is an abutment. C is a crown, and bone where the implant placed. Slide. This is a histological picture of implant placement at week 8. Slide. Nicotine, a major component of tobacco that regulates bone metabolism by increasing periodontal tissue attachment loss and alveolar bone absorption, also inducing peri-implantitis. Nicotine contributes to an increased osteoclast activity, so bone regeneration inhibits that causes bone loss and alveolar bone resorption. The harmful effect of nicotine can be so detrimental that it affects bone healing and affect osseointegration. At early osseointegration and late osseointegration. At late osseointegration can inducing peri-implantitis and affect to implant survival rates. Material and method, lanjut. Reno, lanjut. Material and method, lanjut. This research is an experimental study of 16 rabbits randomized across 2 groups. Group 1 is a control group and group 2 is a treatment group. The treatment group was given 2.5 milligram per kilogram body weight per day of nicotine by injection 1 week before placement implant until the end of research. 1 week later, implant placement at the right jaw, and then 7 weeks later, implant placement at the left jaw. So its rabbits have 2 implants at right and left jaw. 1 week later, all the rabbits were euthanized, and then observation value of osseointegration by osteo tool, and then observation numbers of osteoclasts and osteoblasts by immunohistology tests, and expression of nicotinic acetylcholine receptor and nucleus factor of activated T cell cytoplasmic 1 by immunohistochemia test. Slide. Slide. Data analysis. The data of the number of osteoblasts and osteoclasts, nicotinic acetylcholine receptor, and nucleus factor activated T cell cytoplasmic 1 expression are expressed as mean standard deviation and statistics by analysis of variance and star density tests using SPSS software package version 17.0, a p-value of less than 0.05 was considered to show a statistically significant difference. And the result, there are significant differences were found between the control and the treatment group with p less than 0.05. Slide. The effect of nicotine on osseointegration of dental implant was examined, and the result as shown in table 1. Osseointegration in the first week, there was no significant difference between the control and nicotine group with p less than 0.005, but in the 8 weeks, the osseointegration value in the treatment group was lower than in the control group. Slide. This is a picture of osteoclast and osteoblast cell of bone around the implant with 200 times magnification. Slide. And this table 2, the number of osteoclast and osteoblast cell at week 1 and 8. Osteoclast number increase in the nicotine group at weeks 1 and 8 compared with the control group. Osteoblast number in the nicotine groups were decreased compared with the control group at weeks 1 and 8. Slide. This is expression nicotinic acetylcholine receptor in osteoclast and osteoblast cell with magnification 400 times. Slide. And this nucleus factor activated T-cell cytoplasmic expression in trabecular bone osteoclast with 400 times magnification. Slide. Table 3, expression of nicotinic acetylcholine receptor and nuclear factor activated T-cell cytoplasmic 1 at week 1 and 8. The results show that the expression of nicotinic acetylcholine receptor and nucleus factor activated T cytoplasmic 1 was higher in the first and 8-week nicotine group than in the control group. Slide. This osseointegration barrier schema by nicotine. Nicotine acts as stimulant and inhibitor of bone metabolism, reduce the activity of osteoblasts and affect the collagen that can be used to form the extracellular matrix. Nicotine can also induce microvascular obstruction and reduce blood cell proliferation that impairs healing areas after implant placement. Nicotine also reduces macroproliferation and increases susceptibility to infection at the surgical site of implant placement. This study demonstrated that nicotine also promotes osteoclast formation. This finding is support who states the exposure to nicotine increases osteoclast differentiation and calcium phosphatase absorption during bone regeneration. Nicotine can affect osteoclast formation through several mechanisms. In this study, nicotine induction increase nicotinic acetylcholine receptor expression. Slide. Recently, several studies have linked nicotinic acetylcholine receptor to the regulation of osteoclast formation. Nicotinic acetylcholine receptor agonists such as nicotine and carbachylcholine have been shown to stimulate osteoclast formation. In addition, nicotinic acetylcholine receptor antagonist block most of the effect of nicotine, suggesting that these changes are dependent on nicotinic acetylcholine receptor activity. Yes. We also found that nicotine induction increase nucleus factor activated T cytoplasmic 1 expression is a matter transcription factor of osteoclast regulators involved in osteoclast formation and osteoclast activation. Induction of nicotine induces excessive osteoclast activity and bone resorption, impairing osseointegration of dental implants. Rank induces the nucleus factor activated T cytoplasmic 1 gene in osteoclast via transcription factor such as the nuclear factor kappa B and CFOS. The important role of nucleus factor activated T cytoplasmic 1 in osteoclast differentiation is well documented by several studies. Inhibition of nuclear factor activated T cytoplasmic 1 by cytochalasin inhibits rankle-induced osteoclast formation. Even nucleus factor activated T cytoplasmic 1 deficient embryonic stem cell cannot differentiate into osteoclast in response to rankle. However, nuclear factor activated T cytoplasmic 1 ectopic osteoclast precursors induce osteoclast differentiation in the absence of rank. Slide. Conclusion. Nicotine inhibits the osseointegration of dental implant with increasing nicotinic acetylcholine receptor and nucleus factor activated T cell cytoplasmic 1 expressions, increasing osteoclast numbers and decreasing osteoblast numbers. Like this references. Yes. Slide. My mission is share my knowledge to get another knowledge. So, if any question?
The COVID-19 pandemic cross-sectional study. I'm Fitriani Kahar. I'm Health Analyst Department, Poltekkes Kemenkes Semarang. I'm from Indonesia. Okay. COVID-19 is a new virus that has spread to several parts of the world with the fast transmission process. This virus is an RNA type of virus with a positive single strand that attack the respiratory tract with symptoms such as flu, fever, cough, or shortness of breath. Coronavirus is a virus with disease symptom ranging from mild symptoms to severe symptoms and can cause death. This virus is still in the same family as the mirror is respiratory syndrome and severe acute respiratory syndrome. Various efforts have been made by the government in the effort to break the chain of transmission of COVID-19. Some of the government efforts during the COVID-19 pandemic were the use of mass physical distance, social distance, stay at home, work from home for workers, quarantine for patients with COVID-19 symptoms, and implementation of large-scale social restrictive, or Indonesia, it seems is BB. As an implementation of COVID-19 prevention effort in the campus so that distance learning system is applied. This COVID-19 has caused change in attitudes and behavior in the community People are become more concerned about health and wearing a mask in oblivion. The result of previous study indicates that there is a relationship between knowledge, attitude, and behavior kota gede market traders. So according to Bloom, there are three demands of a person behavior, namely knowledge, attitudes, and action of a person. Knowledge is some understanding of the topic present. Attitude is a defined a tendency towards an object to act, which may or may not support an objective. Attitude is predisposing factor in behavior. And then composing educational environment of the younger generation and creating place for group productive age and become agent of change who can contribute to various innovation in effort to control COVID-19 so that university community can tell all available resource to develop various system in the controlling COVID-19. Medical laboratory technology student or health student who will become prospective health workers in the future, apply and enroll and be role models for the general public in implementing good and clear health behavior patterns. Like this slide, so the government, because distribution of COVID-19 cases, so that government effort during the COVID-19 pandemic, like use of mask, physical and social distancing, and stay at home. So it's a give effect of pandemic was change in attitudes and behavior in the community. We can see in the behavior of community, student, and the other. So behavior it's from knowledge, attitude, and action of a person. So what's the problem? The problem is what is the description of COVID-19 prevention behavior among health students? So what is purpose of the research? This article aims to determine to know COVID-19 prevention behavior in health students so that it become an effort to prevent COVID-19 disease in students. And then it is hoped that this article can be a source of reference for COVID-19 literature in Indonesia. So this research is a type of quantitative research with analytic descriptive design. The population were all students of the Department of Health Analysis, Poltekkes Semarang. Research participant is of the medical laboratory technology student. So that measuring instrument use online questionnaire distributed by via Google Form about behavior with 15 questions. Before being tested, the questionnaire has been tested for validation and reliability with validation value, arithmetic, more than irritable, and Comrade alpha reliable value of 0.73, so that it considered feasible to be a research measure instrument. For the determine of the research score, behavioral questionnaire with Likert scale, behavioral questionnaire score for positive statement are always a score of 5, often a score 4, sometimes a score 3, one a score 2, and never a score of 1, and vice versa for negative statement. So the result of the research, we can see the characteristic of respondent based on socio-demography. The table 1 show characteristic of the student based on a gender, age, study program, history of COVID-19, and the current condition of student. But on the table 1 result descriptive analysis based student that majority of students are female is as 273, age is 20 until 21 years. And then from the diplomatory study program, and majority didn't have a history of COVID-19. There's many 291, so that current condition of the student was in a good health. So the graph one show the category of student behavior during COVID-19 pandemic, namely the very good category of the 16%. A category of 42, and a good category is 66.9%. The natural category of 62. The poor category is only 1. Very bad category only 3. The majority of student behavior was in the good category. Is 66.9%. So this is a distribution of student behavior during pandemic COVID-19. There was 15 questions. So the result able to show that statement item regarding student behavior during the COVID-19 pandemic, which show that the majority of students are disciplined in using masks and implementing health protocol. As an effort to prevent COVID-19, a student 55.1% didn't study. The graph of the category of COVID-19 prevention behavior student can be seen in Figure 2, which show that highest category is good behavior. This result is aligned with research conducted in Nigeria, like the result of research in Karangrejo village, which show that knowledge and behavior of the community are in the good category. So knowledge has an important role in determining one's behavior, because the knowledge, it will form belief, which will then be perceived to be true and become the best for making decision and determine one's behavior on certain object. Green theories in Noto Atmojo show that there are various factors that can influence person health behavior, namely predisposing factor like knowledge, attitude, belief, and others, and then reinforcing factor like family support, attitude, and behavior, and then factor enabling like a physical environment and availability of facility. So the result of the research indicate the general of the respondent have a good behavior. COVID-19 prevention behavior and support must be done and breaking the transmission of COVID-19. So behavior is a form or response to an objective, which will then become a habit because it's considered a value and belief. So behavior is also the act of the responding to stimuli with the environment that can be observed or not observed. So various information about preventing COVID-19, which a recommendation for health promotion has a spread to various media, but print and electronic, such as mask, washing a hand, and avoiding crowds. So that conclusion this of my research, the result of the research indicate the general of the respondent have a good behavior. COVID-19 prevention behaviors and for the must be done in breaking and transmission of COVID-19. So behavior is a form response to an object which will then become a habit because it is considered a value and believe it. So behavior is also the act of responding to stimuli with the environment that can be observed or not observed. So the result of the research can be used by the academic community as a reference in providing policy on a campus to prevent the spread of COVID-19. So what's a suggestion of the research? So the students are still expected to increase their knowledge about COVID-19, trust and accurate source so that they can use the knowledge. They have to implement behavior action to prevent COVID-19. Students are expected to be able to apply health protocol in every activity. So education about the dangers of COVID-19 transmission has continued to be carried out at a massive scale so that it indirect creates a positive attitude for everyone to behave in preventing COVID-19 transmission. Okay, thank you for moderators.
Thank you very much.
Impact the implementation of telemedicine technologies on providing medical assistance to pregnant women. Experience of the Sverdlovsk region of the Russian Federation. I do my research with my scientific advisor, Dr. Natalia Brinza. So let's begin. Today, in the Russian Federation in general, and in the Sverdlovsk regional in particular, telemedicine technologies are being actively introduced in all areas of medical activity. Telemedicine technologies are also used in the provision of obstetric and gynecological care. In the Sverdlovsk region, an electronic medical records was set up for every pregnant woman in 2019. It contains all the information about patient's health and the course of previous pregnancies. Information about the results of the tests, diagnosis, and doctor's prescriptions are automatically added to the electronic medical record. This facilitates not only the doctor's works, but also gives the patient access to information about her health. In addition, a software application has been developed and implemented. The use of it provides free charge to every pregnant woman in the Sverdlovsk region. Let us dwell in more detail on what a pregnancy diary is. It includes the following features: access to an electronic medical record, a reminder of appointment with a doctor, a reminder of taking tests, keeping a diary of a pregnant woman. Keeping a diary of a pregnant woman involves daily recommending by the patients of her health parameters, such as general health status, pressure, pulse, temperature, indication of pain, bleeding, other health disorders during the course of pregnancy. Work with the diary of a pregnant woman by medical workers is carried out both automatically, and a doctor can personally review the record in it. In case there is a life-threatening situation, information is automatically sent to the medical organization. In this organization, the doctor on duty decides on the need of emergency hospitalization. In addition, he can contact the patient and give recommendations. The introduction of the described technologies is undoubtedly very serious and intensive. Therefore, it is relevant to evaluate the economic and medical efficiency of the described telemedicine technologies in order to justify the spread of their use throughout the Russian Federation. The purpose of the study was to evaluate the medical and economic efficiency to determine telemedicine technologies introduced in the Sverdlovsk region. To assess the economic efficiency of the implemented telemedicine technologies, we use the data of the Ministry of Health for the Sverdlovsk region, and the data present in the collecting of statistical materials, main indicators of materials and child health, the activities of the child protection and obstetric service in the Russian Federation for the period from 2016 to 2021. When evaluating the medical efficiencies, a clinical and statistical analysis of medical records was carried out. 15,148 causes of childbirth that occur before the introduction of telemedicine technologies were considered. It includes the period from 2016 to 2018 and the first 3 months of the year 2019, and 12,436 causes after the introduction of telemedicine technologies. It includes the period from April 2019 to 2021. The study was conducted on the basis of the perinatal center of the city of Yekaterinburg, Sverdlovsk region. Statistical processing of materials was carried out using Microsoft Office Excel 2019 software package, as well as statistical package for social science. In the course of the work, the Kolmogorov-Smirnov test was used to assess the normality of the distribution, and the Krashkin-Wall test for key independent samples was used to analyze the difference between groups. Arithmetic mean, standard error, and mean standard deviation were calculated. The significance is different between the compared mean values was assessed using students' t-test. The level of significance of statistical indicators was considered significant and p less than 0.05. Highly significant and p less 0.01, and unreliable at p more than 0.05. In the study, preterm births were divided into 4 groups based on histological age as follows. Extremely early birth, that a birth occurred with a histological period of 22-27 weeks and 6 days. Early preterm birth, that occurs that occurs at 28-31 weeks and 6 days of pregnancy. Preterm birth occurring in 32-33 weeks and 6 days of pregnancy, and late preterm birth occurring at 34-36 weeks and 6 days of pregnancy. It should be calculated that the Russian Federation has introduced a 3-tier system of medical care. According to this system, the first level of obstetric care and gynecological care includes obstetric hospitals and antenatal clinics, where round-the-clock stay an obstetric gynecologist, an neonatologist, and anesthesiologist resuscitation is not provided. The second level consists of obstetric hospitals, maternity hospitals, which have in their structure an anesthesiology resuscitation department for women, as well as resuscitation wards and intensive care wards for newborns. The third level is made up of obstetric hospitals, which includes an anesthesiology resuscitation department for women, resuscitation and intensive care unit for newborns, department of pathology of newborns and perinatal babies, an obstetric remote consultative center with telemedicine department, including mobile anesthesiology and resuscitation ambulatory teams. The third B level is obstetric hospitals of Federal Medical Organization that provides specialized high-tech medical care to women during pregnancy, childbirth, the postpartum period, and medical care on to newborns. Depending on such parameters as the course of the pregnancy, the complexity of the oncoming birth, the condition of the mother and fetus, delivery is carried out on the department of the appointment level of obstetric and gynecological care. Our study was considered on the basis of a perinatal center belonging to the 3rd A level of obstetric care in the city of Yekaterinburg. This means that high-risk patients are sent to this perinatal center for the purpose of delivery. This circumstance makes it inappropriate to assess the change in the indicates of preterm birth. That is why during the study, an assessment was made of the significance of the difference in the proportion of the 4 groups of preterm birth. The group were made up depends on the histological age. Comparison were carried out as follows. Fidelity assessment were first conducted between years in the period before the implementation of telemedicine technologies, and separately in the period after their implementation. The significance of the difference between this time period was that assist. We wanted to determine whether the introduction of telemedicine technologies results in longer histological ages. Given the normality of the samples distribution, significance was determined using the student's coefficient. The difference between the samples was found to be significant and p less than 0.05 level. It was found that the first time period before the introduction of telemedicine technologies, when comparing the proportion of groups of premature birth between different years, no significant difference was found. This means that the difference is random. The structure of preterm births did not change, depends on the histological age. A similar result was obtained for the second time period studied, after the introduction of telemedicine technologies. In this period, there is no significant difference in the structure of preterm birth. At the same time, when comparing the proportion of groups of preterm births between the time period under consideration, a significant difference was determined for the group of late preterm births. The proportion of preterm births with a histological period of 34-36 weeks in the period before the introduction of telemedicine technologies was significantly lower than the period after the introduction of telemedicine technologies. Considering the proportion of occurrence of extremely early preterm births, it was determined that before the introduction of telemedicine technologies, it was significantly higher than after the introduction. Exception is the year 2019. This is due to the large difference in the size of the groups of patients under consideration. The group before the introduction of telemedicine technologies included the first quarter of the year. The group after the introduction of telemedicine technologies included the remaining 3 quarters of the year. In addition, this year can be called transition year, since it is the year when obstetric monitoring program began to be introduced. There are no significant difference in the early preterm birth and preterm birth group. The next effect considered from the introduction of telemedicine technologies was economic efficiency. To determine it, we examined the change in the average direction on the patient's stay on the obstetric bed. According to the order of the Ministry of Health of the Russian Federation 1130, the recommended time for a postpartum woman to stay in a medical organization after physiological birth is 3 days. And the case of an uncomplemented course of the postoperative period after cesarean section is 4 days. However, according to the order of the Ministry of Health of the Russian Federation 185 neonatal screening is carried out on the first day, and vaccination against tuberculosis is carried out between 3rd or 7th day. Therefore, in the case of an uncomplemented course of the postpartum period of the mother and the early neonatal period of the child, the optimal period of discharge from the obstetric hospitals is considered to be in the 5th or 2nd day after birth. During the study, the average length of stay of a patient in an obstetric bed was assessed separately from maternity hospitals and perinatal centers. This is due to the fact that delivery of pregnant women at high perinatal risk is carried out in department of the 3rd level of obstetric care in the perinatal centers, and physiological births are carried out in department of the 2nd level of obstetric care in maternity hospitals. Therefore, it is logical to expect higher average lengths of stay of a patient in an obstetric bed in perinatal centers. We took to the data of the Ministry of Health of the Sverdlovsk region and data of the collecting of statistical materials, basic indicators of materials in child health, activities of child welfare and obstetric service in the Russian Federation for the period from 2016 to 2021. According to this data, the average length of stay in an obstetric bed in maternity hospitals in the Sverdlovsk region corresponding to the recommended indicators. There is this decrease in the indicators from 5.5 days in 2016 to 4.7 days in 2021. In the perinatal center, there is an increase in the average length of stay in an obstetric bed by 1 day, which corresponded to expectation. Based on our research, we can draw the following conclusions. The introduction of telemedicine technologies into the pregnancy management program has shown positive results, both from an economic and medical point of view. There is a reduction in the number of extremely early preterm births from 11% in 2016 to 7% in 2021 of all preterm births. The fact that the possibility of remote monitoring of health allows the patient to not to be hospitalized in a hospital for observation led to reduce in the length of the patient's stay in the obstetric bed from 5.5 days to 4.7 days. That's all. Thank you for your attention. I'll be happy to answer your question.
Okay, thank you very much, Dr. Maria. Any question from audience? Any question more?
Could you please help me how I can stop to changing of the presentation?
You can stop share.
Share, yeah, where?
Yes. No. Yes. Have stop share. Okay.
I don't know. See, I haven't seen where.
Not share now. Okay, from I think enough from audience. Any question or not? Or you can click stop share. Okay. Okay, for the thank you. If there is no question from audience, we will to the next presenter. Thank you, Dr. Maria, for your great presentation. For the next presenter is Ms. Seida Yilmaz Ozal. Can you hear me?
Yes, I can hear you.
Okay. Thank you from Ms. Seida.
This robotic system, always measures forces opposed by the body to catheter and guide wire advancement, which, if it is too high, may cause big problems for the patient because it ruptures the vases. This system allows endovascular surgery in any portion of the body, starting from introduction of a first catheter, which may even be curved, always separating the doctor from the patient. And once the first catheter has been introduced, it's possible to pass to the specific surgery. We have a small disposable, purely mechanical, designed for any size of catheters and guide wires and for special applications. We always measure advancement and retrieval of all devices introduced into the body and transmitting the advancement and the forces to a workstation. We can, recording also the pictures, we can basically obtain the black box of endovascular surgery. A single system, allows any surgery from angioplasty to brain and carotid TAVI, transcatheter aortic valve implant, upper and lower limb aneurysm, stenosis, or any other vascular problems. How did we start? We started inventing basically, which is the basic mechanism, which consists in, it's a question of gears. Okay, now this system may have 3 degrees of control that are actually controlled by the console with 2 joysticks. And on the right, I don't know if you can see, this is the robotic actuator, and these are the first disposables that we made for this particular. This system was tested in hospital, even on patients, and here it's the picture of the first trial that was on 19, and here you can see a stent implanted in the heart of a patient. More things on roses. As I said, may position the first catheter in the vascular system, controlling advancement and rotation, while controlling in a totally independent way a guide with a movable core, which may be useful to straighten the parts of a catheter that are pre-curved, if it is useful, if it is necessary. And everything is used by the following procedure. Everything guided by the console. It is enough to change the program and eventually change the disposables. A single robotic actuator may be used for angioplasty if the first catheter is positioned manually. Several patient trials were performed this way. As we have, I said already, we have small disposable components, and we may use more robotic actuators in series, as you will see. We developed also a device to control animated catheter, are those catheters which may move, for instance, the tip or even another portion. And we have USA and European application covering the entire thing. Okay, this image shows why I said that we can measure the forces. Our system, as you can see, has a long rail which is inclined toward the patient, on which can be placed 2 or 3 robotic actuators sitting on a slide which runs smoothly on the rail, and always on the rail is also another slide which holds 2 motors. The first robotic actuator, the proximal, the one that is closest to the patient, is fixed to the motors by a sidebar, while the other 2 are movable by worn screws that move the catheters. Now, the entire thing would fall on the patient if it were not fixed at one point. And this point, where it's fixed through a cable, is the sensor of forces. So this sensor of force always feels the force due to the fact that these things, the G component of the weight of these things. And this G component doesn't change if these things move, if the motor run, etc. It only changes when a catheter that is advancing meets a resistance in the body. And this is immediately referred to the doctor so that the doctor has control and can avoid to damage the patient. And this is very important. The other thing, as I said, is the ability of measuring how long its penetration, and this is done because inside the robotic actuators are step motors, so we know how many steps are made. We know the transmission ratio between the step motors and the friction wheels, so we know everything, and we compute from the beginning the advancement, and this is what can be transmitted to the workstation. But we can also measure the length of stenosis, so that we can choose the length of stent before actually placing it. This is the picture of the old and the new robotic actuator. The old was the one that was used only for angioplasty. The other one is the one that can be used for everything, including aortic valve replacement. And you can see that the difference is the big hole. The mechanics is identical, is only the numbers of teeth that change, but through this hole, it is possible not only to pass big catheters, 8 millimeters of diameter, or stuff like that, but even the valves, hemostasis valves, which is needed when placing the TAVI. Okay, now having changed the central hole, we also have to change all the disposables. And so here is the first one that was studied only for big catheters. And then below you can see the new catheter for angioplasty, the new disposable for angioplasty, and the new disposable for moving the core of guide wire with movable core. Competitors. Who are the competitors? Well, one competitor is Magellan by Hansen Medical, which has a special catheter which with the tip that can change curvature. But besides that, it can be used, it uses only small catheters because this catheter clearly has to be there, and basically is able to perform only vascular surgery, no angioplasty. The second one, Corindus, Corpath by Corindus, instead is specialized for angioplasty, while our system is the only one that is able to do both vascular surgery and angioplasty. You just have to change the program and the disposables. The third one in the bottom, it's a French, basically, it's a French copy of Corindus. Now, what about the market? Well, only in Italy there are 500 centers, and here a picture of centers in the United States that participate to a certain study, but this does not represent at all the number of centers present in USA. So we believe that overall the number of centers in the world is between 5,000 and 10,000, which is a lot. And the picture below show the growth of the market of these catheters. Commercial and marketing strategy. First, we have to get EC mark for roses and register our brand. Then we'll find a certain number of key centers all over Europe to give our equipment for free, in free trial, promising big discounts at the end if they accept to become the training center for their country. We need to get an experienced marketing manager, start product specialist. Of course, we'll participate in congresses, international fairs, And eventually, with useful agreement, we may give our distribution to big firms like Philips, Siemens, GE, or whatever. But in any case, with our brand producing here and leaving to them commercialization. This is just a list of the articles that we wrote on this topic, and those are just the international patents. Now, this is an investment opportunity because it's a game changer. We request basically 1,500,000 shares and 500 multi-annual loan because we can bring our capital to 1.6 million, converting notes into capital, etc. But we are ready to listen other proposals. Beside, we'll have further funds from EC. We made an EIC application, 2.5 million, from the Italian government and regional no-refund funds. These funds will be used for registration expenses, enhance product capability, and buying assets. Revenues, as you can see from this, well, first of all, I have to say that the production cost of our system is about 25K, while sale price will range, depending on the model, the simpler or the most complete, from 200K to 500K. And so the margin is satisfactory. So that since we are going to start basically the sales after registration, and we are already starting the registration process, so that we believe that in the middle of next year, not only of 24, but 25, we'll be able to sell the first units, and then the growth will be steady. Okay, this is our team at the moment. Thank you very much. If you have any questions, you can ask now, or you can send me question at my email, which is danieli@uni.
So adolescents actually represent a crucial development stage where lifestyle patterns often solidify, exerting a profound influence on lifelong health habits. This period is suited between infancy and adulthood, necessitate adequate nutrients intake to support growth and lay the foundation for future well-being. However, a noteworthy trend emerges among university students, within many adopting unhealthy dietary practices that can determinately impact their overall health. So previous studies have systematically identified and categorized various factors influencing nutritional knowledge, encompassing curricular gaps, socioeconomic factors, and lifestyle practices. Examining these factors enhances the understanding of the interact and multifaceted nature of the subject at hand. University students commonly encounter challenges in maintaining a nutritious diet. So furthermore, personal, social, and environmental influences shape their dietary choices. Coupled with stress from exams, peer pressure, and changes in university life, these factors make it difficult for students to prioritize healthy eating practices. Consequently, this places them at an elevated risk of developing non-communicable disease associated with poor nutritional practices. Acknowledging nutritional knowledge as a fundamental determinant in health promotion, disease prevention, and overall well-being underscores its critical significance within various demographic groups, in particular university students. So this focus is articulated with precision as we delve into the aspects of its importance, specifically centering on understanding health, disease, food intake, nutrient sources, and adherence to nutrition standards, as shown in this figure. So let us speak about the relationship between nutritional knowledge and health. So there are extensive research that has shed light on the close association or relationship that exists between dietary knowledge and the influence that it has on health outcomes. When individual possess a high level of nutritional awareness, they are more likely to make healthier choices about their diet, which results in a lower chance of developing chronic diseases and an overall improvement in health. For the second domain that had a great impact on nutritional knowledge, which is disease prevention. According to the research that has been conducted, and revealed that a lack of nutritional knowledge may be one factor that contributes to the increasing prevalence of nutritional related disorders among university students, highlighting the importance of implementing specific educational intervention. On the other hand, it is essential to keep in mind that merely expanding one's knowledge of nutrition does not, on its own, ensure that individuals' attitudes toward nutrition or their eating behaviors will alter immediately. Moving to nutrient resources, as the first aspect of examination revolves around students' awareness and the comprehension of nutritional principles. This encompasses understanding macronutrients, micronutrients, dietary guidelines, and the broader context of nutrition education. There are studies within this realm shed light on the extent to which students possess foundational knowledge regarding the nutritional component of their diets. So understanding where nutrients originate and how they contribute to overall health is crucial for making informed dietary decisions. Last but not least, the nutritional standard and its impact has a great impact on nutritional knowledge. So the nutritional standard and the dietary behaviors of university students represents a vital domain of investigation, given the pivotal role these standards play in shaping the health and well-being of this demographic. So as we delve into the existing body of research that constantly highlights concerning trend, university students often exhibit inadequate knowledge of nutritional topics, and by thoroughly examining this dimension, the present study was conducted to assess the general nutrition knowledge among nursing students in the UAE, considering demographic variation in knowledge level, and investigate the correlation between participant perception regarding the interplay of diet, disease, weight management, and their performance on the general nutrition knowledge questionnaire. The present study was a cross-sectional, correlational, and descriptive study carried out in the nursing department of Fatima College of Health Sciences, located in United Arab Emirates, throughout the academic year 2022-2023. And this study is centered on female students only, given that the institution student population consists mainly of women. And the study comprises nursing students who are currently enrolled in levels 2 up to 4. This inclusion requirements pertain to students who initiated their enrollment in nursing program at the commencement. For the API Info 7 software was used to ascertain the number of participants, and the calculation considered as 5% variation, 95% confidence level, and a statistical power of 0.8t at a significant level of 0.5. The demographic data collected encompassed several aspects, including gender, marital status, self-perceived health condition, enrollment in a nutrition course, and living situations, including children less than age of 18. The authors of the study adopted a validated tool, which is the revised General Nutrition Knowledge Questionnaire, which was previously described by Clement et al. In 2016. And in this study, the General Nutrition Knowledge Questionnaire a scale comprising 88 items distributed across 4 dimensions, namely dietary recommendations, nutrient resources, healthy food choices, and the diet, disease, and weight management. The researcher also evaluated the internal consistency of the study tool by employing Cronbach alpha coefficient test in order to ascertain the reliability, and the finding revealed that a substantial level of reliability, alpha equals 0.88 at a significant level of 0.05. The study protocol, research instrument, and consent documentation were submitted to the research committee and obtained the approval to conduct the study. With regard to the statistical analysis, the data underwent statistical analysis using SPSS 20. Demographic characteristics were quantified using descriptive statistic, which encompasses measures such as frequency, means, standard deviation, minimum, and maximums. And to investigate the relationship between variables, the study applied a Pearson correlation coefficient, and all statistical tests were performed at a significant level of 0.05. As you can see, for the socio-demographic characteristics displayed in the table, illustrating a comprehensive overview of key factors within the sample, the gender distribution indicates a homogeneous representation with 100% of respondents being female, and marital status delineates predominant representation of single individuals at 94%, with minority comprising married participants. Body mass index showcases a distribution wherein 68% of respondents fall within the underweight and normal body mass index category, and the health reveals 70% for the participant, the mean body mass index is presented as 23.6, and the participant perception of health reveals 7% perceives their health as poor or fair, while 57% is rated as a good. This table presents a comprehensive overview of the participants' mean percentage score of the General Nutrition Knowledge Questionnaire. The overall mean percentage score of the General Nutrition was 53.86, indicating a moderate level of nutritional knowledge. And it is noteworthy to mention that a majority of 73% exhibited a comparable level of knowledge, whereas a minority 27% achieved scores that fell below the threshold of satisfactory results. This table presents the correlation coefficients and corresponding p-values explaining the relationships between the responses of the participants of diet, disease, and weight management and their scores of the General Nutrition Knowledge Questionnaires. The data reveals that there is a statistically significant positive relationship between participants' overall nutrition knowledge and their perception of actually, it was statistically significant between the overall nutrition knowledge, healthy food choices, food groups, dietary recommendation, along with their understanding about diet, disease, and weight management. The relationship between perception of diet, disease, this table provides a comprehensive overview of both univariate and multivariate regression analysis aimed at highlighting the factors influencing general nutrition knowledge within the sample of 200 participants. The univariate analysis reveals a non-significant p-value of 0.3 for health perception, suggesting that in isolation, health perception may not significantly predict general knowledge nutrition. Conversely, the univariate analysis for participants having children under 18 exhibits a highly significant p-value. This indicates a robust association between these variables and general nutrition knowledge. In the multivariate analysis, additional insights are provided, notably having children less than 18 years, the variable retained its significance with p-value and an increased odd ratio. This underscores the robust and independent predictive capacity of having children less than 18 years for higher general knowledge, nutrition knowledge. So to conclude, in hospital system, nurses our current student nurses play a crucial role in influencing patient and particularly regarding their nutritional status. So these students or nurses should be equipped with sufficient information and should have both the needed knowledge to qualify them to deal with patient confidently. And it is in additional, it is crucial that nursing students graduate with a strong understanding for the domains of nutrition, because nutrition is integrated in all aspects, most probably with whole diagnosis that the students dealing with in hospital. And this is the end. Thank you for listening.
Okay, thank you very much, Dr. Rasa Ibrahim, for your great presentation. Any question from audience? From audience, any question?
That we're going to discuss today. And basically, marijuana. Marijuana is the most commonly more popular widely consumed drugs among Americans. 18% of Americans have tried it at least once, and it's used. We can see it over here in contrast to other drugs and other misuses of drugs. It's huge, and basically, it's more common, twice as common, to be consumed by women than by men than women. So annually, about 2.5 the world's population roughly consumes this drug, and that's in contrast to opiates and cocaine. That's 0.2 about. So that's massive. So basically, we have a lot of components in marijuana, and a lot of them have been shown to have beneficial medical effects, and they have been isolated, also been prescribed for many conditions such as glaucoma, epilepsy, cancer, cachexia, but that doesn't take in the adverse effects or the risks that it can have in patients that consume them recreationally or even therapeutically. So they can have neuropsychiatric effects, so they can cause anxiety and depression. Mainly, this will be the THC, that's the one that's going to have the neurological and psychological effects. They can also cause impairments in cognitive function and memory. It increases actually the risks for respiratory infections because this is an smoked substance, and also carries some cardiovascular risk factors or life threatening, such as acute myocardial ischemia, and also changes in blood pressure, and also some arrhythmias such as tachycardia. So getting into male infertility, what's infertility first? So infertility is basically a failure to achieve pregnancy after 12 months or more of regular unprotected sexual intercourse. So it requires basically two patients in order to make the diagnosis. So you have a male and a female patient. But male infertility, so can be driven or will be driven or classified as these four factors due to semen ejaculation, sperm counts, sperm morphology, or sperm motility. In the ejaculation, we can have causes such as obstructions and infections. And sperm count, we're going to have causes of hypogonadism, either primary or secondary, so things that affect the testis itself or affect the axis or the hormones that have influence in these testes. So with the morphology, we have motility commonly is due to anabolic steroid use. And those are kind of a brief touch on the causes of male infertility. So the methodology that we follow was exploring these databases and putting in these keywords and screening through all these articles. And we finally got 15 articles that were assessed for risk of bias too, each one for its type. So we got studies, case control studies, we got cohort studies, we got traditional reviews, we also got longitudinal reviews, systematic reviews in cohorts, more cohorts, and now I want to touch on a bit about the physiologic processes that happen and that are affected by marijuana or cannabis, such as spermatogenesis. So the spermatogenesis is actually the process that will form the sperm cells. It will start with a primordial germ cell in the testes, in the seminiferous tubules, so they will mature furtherly with mitosis, meiosis, and they will form these spermatids, and they will then mature into sperm cells, and they will go and be stored in the epididymis, we can see over here, until ejaculation. So the thing to highlight is that high concentrations of testosterone are needed for this process to happen, and that process can be affected then by marijuana. I will jump into that later. Here we have the anatomy, kind of the morphology of the sperm cell. We have the head. We have the acrosome. Basically, that's a zone that contains some enzymes that will help the sperm go into the egg cell when it's fertilization time. And we also have the midpiece, where we can see, and I want to highlight the high concentration of mitochondria that we have over here that will promote ATP and energy in order to move the flagellum and all the microtubules in the tail. So that's it. All of that happens in order to fertilization to happen. And fertilization basically will be a process with a lot of steps, but it won't start without capacitation. So when the sperms are ejaculated into the female reproductive system, in order for them to reach the ovum, they will need to go into a process of capacitation. So capacitation will be induced kind of by the endometrial fluids that will promote changes in the sperm cell, specifically in the plasma membrane, readjusting some glycoproteins. But the main thing is that these changes will kind of prime the sperm cell for the acrosomal reaction to happen, and then for the fusion, and then the zygote formation, and then the fetus formation eventually. So in order for the acrosomal reaction to happen and the sperm to get there, he needs to be kind of faster than the other one. So this will be driven by an overload of calcium inside the cell. And I will jump into that later on, because that's relevant for the mechanisms and how marijuana affects, or cannabis affects the sperm cells. So getting into the endocannabinoid system, I want to highlight that it was described just a few years ago, in the 1990s, and this was described first by this man, Raphael Mechoulam, and his team in Israel in the 1990s, and they found this widespread of receptors throughout the body, mainly CB1, CB2 receptors, as we can see over here. We can have them isolated or in combination in some tissues, such as bone, pancreas, liver, and the reproductive system are focus of today. And here, I want to highlight again the the morphology for the sperm cell, and actually say that the concentrations of the CB receptors that we have over here, the CB1 and CB2 receptors, will be kind of all over the place. But the CB1 receptors are ones that are pretty relevant, that will be more concentrated in the head and the midpiece, and that will take a place in the mechanism for cannabis later on. So keeping up with the endocannabinoid system, here we have the cannabinoids. So we have exocannabinoids such as the THC and CBD, and we have endocannabinoids such as AEA or anandamide and 2-AG, and some synthetic forms that have been developed recently. But the two main they are more endocannabinoids that we have are anandamide and 2-AG, and these endocannabinoids were described with the team of Dr. Raphael Mechoulam in the 1990s, 1992, and basically they will bind to these receptors and have different effects on different parts of our body. Here is a representation of kind of the whole system taking place. We can see over here the CB1 receptor, the CB2 receptor, We can see the cannabinoids. We have them going into neurons in this case. And another thing that I want to highlight are these enzymes that degrade kind of this endocannabinoids and cannabinoids into their main components, composed of glycerol, arachidonic acid, and other components. This is a pretty similar process that we have with acetylcholinesterase that will degrade the ACH. So in fertilization, I want to highlight that process of capacitation again, because as I just said before, it will be driven by a lot of calcium inside the sperm cell. So how would that calcium get into it? And so basically, it will come from the stimulation of a receptor, in this case, the TRPV1 receptor. The endocannabinoid that will bind to this receptor will be anandamide. Anandamide will also bind to the CB1 receptor that's also here, but the TRPV1 receptor will be kind of essential for this process to happen because with the signaling, capacitation will take place, and that means that the acrosomal reaction will take place, and the fertilization, the whole cell will take place, and the fetus will form, and we will have a child. So basically, if we disrupt either the levels of anandamide or the signaling of the TRPV1 receptors, we have decreased levels of calcium by any means, we will have the opposite process. Remember, this process is on the female reproductive system, but in contrast to this, we have this process inhibited in the male reproductive system, as I just said before, when the sperms are maturing in the epididymis and they're waiting for them to be ejaculated. So there will be a stimulation from the anandamide that is on the seminal fluids through the CB1 receptor in this case that will inhibit this process of capacitation for it to not take place in the male reproductive system because we don't want that process to take place there. We want them in the female reproductive system. So that's it. I want to start about with the findings of the sperm capacitation alterations that we found in some studies. So we found that there were differences in the endocannabinoid systems of the sperm cells in fertile males and infertile males. So what was found actually in this study was that the signaling or the expression of the TRPV1 receptor was decreased in those that were infertile. So remember, these are just infertile men. And also the anandamide levels, that's more amazingly found, were found to be decreased, and also the levels of 2-AG were found to be decreased. So similar stuff was found when researchers put some THC into the sperm cells in vitro. So they put THC in the sperm cells in vitro, and they found similar findings. They found decreased levels of anandamide, decreased levels of 2-AG, and they found the decreased expression or signaling of the TRPV1 receptor. Also, what they found was that increase in this exogenous THC was going to drive a CB1 through a CB1 agonism, an inhibition of the capacitation process, and basically this mechanism will drive men infertility in this regards. So in regards to sperm count, also was found to be decreased, and this was in patients that were smokers, in contrast to patients that didn't smoke, that were found to be like a 30% decrease in their sperm count, in contrast to those that never had smoked marijuana. And also some older studies, they suggested an even higher rate, and also a dose-dependent exposure. In regards to morphology, what we found was these two studies, similar studies made in clinics, that one was in a male clinic, and the other one was in, as we can see, in a fertility clinic. So what they found that was the patients that had history of smoking, even before the sample was taken, so even the week before the sample was taken, they were found to be an aberrant morphology of the sperm cells. So in contrast, patients that stopped smoking 1 week before the sample was taken, they were less likely to have this abnormal sperm cells. So a mechanism for this was proposed in mouse studies, and it is actually regarding to that spermatid and that precursor cell of the sperm cell. So a chromatin remodeling, so a kind of a remodeling or rearrangement in the DNA will kind of drive. They proposed that this was the drive for this mechanism, or this normal morphology. And actually, it has not been tested in humans, but it was described to be the same mechanism in mouse that in men until now, at least. So we found the opposite in this study, but was just one study in contrast to all of these studies that we found before. In regards to motility, what happens here is interesting because we can either have an effect through the CB1 receptor and an effect through a CB2 receptor. So we can have through a CB1 receptor, as I just said before, an inhibition of the capacitation process, but we can also have a decrease in the motility process, specifically in that zone where the mitochondria are highly concentrated, the MICPs that we can kind of see over here, and the opposite can be found with through the CB2 receptors. So the CB2 receptors will increase the motility in sperm cells that are sluggish or slower. So it was thought before that the CB2 receptor didn't play a role on it, but it was found more recently that it does. And we found then some pathologic, let's say, findings in patients that smoked or were or sperm cells that were exposed to THC. In vitro, they were again exposed to THC, in this case the delta-9, and they were found to have a decreased motility, hypothesized to be through that CB1 receptor because of an agonism to all of this load of THC. And also similar findings were found in Jamaican men that were usually smokers of marijuana, and they found to have decreased motility in their sperm samples too. So the sperm motility in this study was found to be increased. That's kind of a controversial finding because they also found a normal morphology and a normal decreased volume, but they found increase in motility. That's something to highlight there. And being done with the morphology and the sperm cells and the capacitation and all that, I want to move on the other part of it that are the hormones. The hormones are actually pretty clear. Testosterone levels are found to be variant among studies. Same thing is with FSH. FSH is more clear in women, that is actually found to be decreased, but in men, it's still controversial. And with LH, the opposite is true. So we have found in these studies to be decreased in when exposing to smoking marijuana. And then the study that did this was actually given 8 to 10 cigarettes per week and found to have lower levels of LH in contrast to those that were not consuming it through that period. In regards to testicular size, so here was proposed by an animal study that the oxidative stress of the THC will damage or decrease the testicular size overall. But this was a study made on Nigeria on adolescent patients, young adult patients, where they measured with ultrasound the testicular size, and among users, they were found to have a decreased testicular size, but this was in a small sample of patients. Regards to sexual function, actually, there's a brief increase in sexual libido because of the psychogenic effects of marijuana, but actually eventually will wane down and decrease the libido and cause erectile dysfunction overall. It has been exposed in this article from Nature with about the comparison of 73 versus 8% patients that are not exposed to cannabis. And in conclusion, actually, we have hypogonadism overall, either to primary hypogonadism, not sure about the secondary hypogonadism. I mean, that HPG axis of the hormones, but actually it's kind of pretty clear that we have oligospermia, so decrease in the count, and teratospermia in the morphology, kind of with the mechanism proposed there, and also we have abnormal motility, and the fertilization process is affected because the capacitation is altered, and if that doesn't happen, fertilization won't take place as it should. Also, there's decreases in libido, as I said before, and erectile dysfunction, and we recommend actually all the clinicians to potential effects of this cannabinoids when they are prescribing them, but most importantly, actually, when they are evaluating infertility, to take factors of this nature in count. And more research, of course, is needed in regards to the HPG axis in larger samples. That's all. Here's a little quote, and thank you so much for your attention. Here's if you have any questions.
Okay, thank you very much, Dr. Jacqueline, from your video presentation. Any question from audience?
Of asthma, and to avoid exacerbation of bronchial asthma. So the objective is to assess the best method and the effective way to control mild bronchial asthma in adults. Next. So next, please. So next, please. So the reason of this on mild asthma, to the best of our knowledge, failure to control mild bronchial asthma may end up with moderate and severe asthma. Undetermined accurate definition of mild asthma usually lead to underestimation of this category of by both patients and physicians. Unnoticed deterioration of pulmonary function of patients with mild bronchial asthma over years highlights a question about what is the best strategy to treat mild bronchial asthma. Next. Next, please. So our design this study, this is comparative study, comparative analysis, and the setting in military hospital in Jabir al-Ahmed Military Hospital in Kuwait. And the participants in this study is 30 adult patients with mild asthma who were followed in outpatient respiratory clinic within 6 months. They were divided into two groups. Group A, who used fluticasone 125 microgram together with salmeterol 50 microgram, and Group B, who used budesonide 160 microgram and formoterol 4.5 microgram only when needed. Next. So the intervention is follow-up through regular visits in chest outpatient, where pulmonary function test, number of ER visits over 6 months, use of systemic steroids, and symptom control using asthma control test, ACT. So this is the outcome measures, and this will be measured in every visit over 6 months. Next. Next. So the results of this test is this study is two groups showed exacerbations over the 6 months treatment. However, group A, who used fluticasone 1 to 5 micrograms and salmeterol 50 microgram, shows less emergency attendance rate for bronchial asthma and less symptoms than group B. We use budesonide 160 microgram, formoterol 4.5 microgram. Group A showed improvement of FEV1 than Group B at the end of 6 months period. Group A showed less symptoms, less systemic steroid use, and less ER visits for bronchial asthma exacerbation. Next. So the conclusion of this study that proactive management with mild bronchial asthma seems to be the best strategy and the effective way in treatment of mild bronchial asthma than reactive approach. Next. So now we will speak about the the bronchial asthma as a whole. As you know, the asthma is a chronic inflammatory disease. It means that the inflammatory markers, the inflammatory cells, are playing a very important role in the pathogenesis of asthma. It is a heterogeneous disease as defined by GINA guidelines. It is defined by its variability over time and intensity as well. The symptoms which define asthma, like wheezes, shortness of breath, chest tightness, and cough, are variable. Different methods are used to measure these symptoms and connect them to the intensity of asthma and subsequently the management, like ACT, which we have used in this study. Asthma symptoms are the tip of the iceberg, which indicates the underlying inflammation. The regular ICS reduced inflammations and intermittent use in our study, in one study over 1 year. So this, as you see, this is the iceberg which we are seeing always in seeing in this condition. So as you see, this is the bottom of the iceberg. This is the inflammatory condition which we use the ICS, inhaled corticosteroids. As you see here, this is too many inflammatory markers like interleukins, interleukin 5, interleukin 25, 33. This is the inflammatory condition which happened at the bottom of the iceberg, which means that you need to control these inflammatory markers, because if you leave this one without treatment, it will lead with the progression of the disease will lead to decreased in the pulmonary function test, and hence increasing the exacerbation of bronchial asthma, and which in turn increases as well the deterioration in the pulmonary function test. So this is the bottom, which is not seen by the patient, but the patient will feel it when coming into that. The definition of mild bronchial asthma, this is the asthma in which symptoms occur more than 2 days a week, but don't occur every day. Wheezes, cough, chest tightness, and cough. Exacerbations that interfere with daily activities. Nighttime symptoms occur 3 to 4 times a month. FEV1 from 65 to 79%. It is not accurate definition, actually. That's why we have to define mild bronchial asthma, because it is a widespread type of asthma. So next, please. So what the data? Next. So the data here, which in our study, this number of our patients is 30 divided into 2 groups. 15 in each group, and the first group, the group A, which is the patients who are using fluticasone salmeterol, and the group B, budesonide and formoterol as needed. Next. So this is the number of the patients who shows change in FEV1 over 6 months in each group. This is chart 2A. We'll find that 9 patients show in group A showed change in the FEV1, while less than 5 patients in group B should change in FEV1. Yes, please. Next, please. So in this chart, actually, you find the change in FEV1 after 6 months in each group. This is chart 2B. As you see, the patients who are using the salmeterol, fluticasone salmeterol regularly, as you see here, there is difference in pulmonary function. As you see, from 73% to 78, more than 78%. This is a significant difference. While the patient using the budesonide 160 microgram formoterol not in regular basis, it means that when needed, show a difference, but which is not significant. There is a big difference between both. However, we started with a baseline, which is 73 for both groups, but the difference, the significant difference shown in the group A. Next, please. So this is a discussion. GINA 2022 reported detailed important changes in mild asthma management, including that SABA is no longer indicated in mild asthma. Instead, we can use ICS formoterol as needed. We agree that the changes as inhaled steroids is a cornerstone in the treatment of inflammation. However, we argue against use it as a reliever only in mild asthma. Why with this argument? Because the argument is based on the fact that, next please, that the fact that, next, the argument is based on the two things. The fact that the disconnection between mild and moderate asthma is subjective. And the second reason is the inflammatory process needs to be controlled in all time and not when needed only. This is inflammatory process. So the use of inhaled corticosteroids formoterol as a reliever will lead to a gap in the treatment. It means that there is a gap, there is exacerbation, there is deterioration of the pulmonary function, which may be missed in the ground of the lack of accurate definition of exacerbations, at least in its intensity. This is our argument regarding GINA 2022. So mild bronchial asthma is considered a challenge as it is widespread among population. Failure to treat patients with a category of asthma may lead to progress into moderate or even severe asthma. Over decades, all attention would be directed to the treatment of moderate and severe asthma due to its impact economically and on mortality as well. However, the treatment of mild bronchial asthma may be underestimated by patients and physicians, and hence the importance of the mild bronchial asthma. Next, please. So increased symptoms and frequent exacerbation of mild bronchial asthma, usually treated as outpatient with bronchodilators and temporary systemic steroids, and subsequently impact on pulmonary function test over years. I would say that appropriate treatment of mild bronchial asthma could lead to preventing exacerbation and may prevent shifting of asthma from mild to moderate and ultimately to severe type of asthma. That's why we have to find the best strategy for treating the mild bronchial asthma. Actually, this is a small comparative study. We proved that the proactive management of bronchial asthma decreased the symptoms significantly, decreased the exacerbations, and decreased the systemic use of steroids. In chart 2A, there is FEV1 change in 9 patients from group A and 3.75 patients, the change of FEV1 in group B. So the significant change from the baseline FEV1 in group A from 73% to 77% in 6 months, while the change in FEV1 in group B was from 73% to 74%. ER visits indicate the number of exacerbation over 24 weeks was 16 visits in group A in comparison to 40 visits in group B, which indicate this is significant reduction of exacerbation. As you see, it's 50% decrease in the group A, which follows a proactive management with the fluticasone and salmeterol regularly. I mean, when we mean by proactive, we mean that we need regular treatment and not intermittent or when needed as well. So the use of steroids in this study actually show a significant reduction in group A, where 20% of group A used systemic steroids in comparison to 67% of group B has used systemic steroids. Instantly, achievement of asthma control has reached 92% in group A if you entertain symptoms using ACT in comparison to 52% of group B. There is a difference, 92% to 52%. The limitation of this study actually from different perspectives is a limited numbers of patients who use only 30 patients. So we encourage physicians to start taking the opportunities to find out what's going on in mild bronchial asthma, which is widespread actually. Next, please. So the conclusion in this study, these results suggest that the proactive management of asthma lead to control of asthma and decrease exacerbation, confirming the effect of proactive management and its effect on the future asthma burden. This is a conclusion of the study, and actually I hope that maybe we can find the best strategy. This is to the best of our knowledge, and this is our study, which took over 6 months just to prove that the proactive management to control the inflammatory effect of asthma and to control patients by using the regular medications over 6 months, it improved the pulmonary function test, the symptoms, decreased significantly the exacerbations, and decreased the steroid use as well, systemic steroid use as well. So we suggest that the proactive management of asthma lead to control and is the best strategy for treatment of bronchial asthma, mild bronchial asthma, and hence preventing shifting of the patients from mild bronchial asthma to severe asthma. And thank you very much. Thank you for thank you very much.
Thank you very much, Dr. Adel, for your great presentation. Any question from audience? Any question?
Very important factor in the rehabilitation process, because they are the first to come into contact with children with neurodevelopmental risks and developmental difficulties and their families. The doctor assesses the child's physical and health development, sets a diagnosis, monitors the child medically, and provides guidelines for early intervention programs.
Hello, Dr. Samra. Sorry for interrupt. Actually, your voice is like, it's not audible. Could you please be a little louder?
Louder.
Could you please be a little louder?
It's okay now? Of being at risk for or known to have developmental and behavioral disorders in intervention programs. The goal of this research is to examine the knowledge of pediatricians and pediatric specialists about speech and language development in accordance with developmental milestones from birth to 5 years of age, and to examine what here they are familiar with the concept of developmental behavioral pediatrics and its effects during the life of a child who suffers from developmental or behavioral difficulties. Initially, 26 pediatricians were contacted for the needs of this research, out of which 15 accepted to be a part of the research. All the respondents are employed in primary and secondary health care and come from the different cities in Bosnia and Herzegovina. For the needs of this research, we have constructed a questionnaire for examining views of pediatricians on speech and language development. A questionnaire was constructed according to the model of developmental milestones in speech-language development recommended by American Speech-Language Hearing Association, and questions related to developmental behavioral pediatrics were based on the literature reviewed. Questionnaire consists of 22 questions, and it was delivered to the respondents via their personal mails. Questionnaire had 3 sections. The first section was related to demographic data. Second section was related to questions about speech-language difficulties and views of speech-language development from childbirth to the 5th year of age. Third section was related to views and questions on developmental behavioral pediatrics and knowledge related to early growth and development acquired at a specialist study, and opinions about significance of multidisciplinary approach and cooperation with speech therapists, defectologists, and psychologists. The data was processed using the statistical program SPSS. In the statistical processing of the data, the frequency of the result was calculated. The result of this research indicated that the surveyed pediatricians mostly encountered children with difficulties in speech-language development on a daily basis, most often children with delayed speech-language development, somewhat less children with difficulties in pronouncing sounds, and less often children with disordered fluency of speech. The majority of pediatricians answered the question statements about speech-language development correctly. They completely agreed with these statements, which indicate that the examined pediatricians have good knowledge in the field of speech-language development. You can see the results, also questions and answered of pediatricians. Also, it can be concluded that the examined pediatricians mostly support and practice multidisciplinary approach in detection and diagnosis of speech and language difficulties. When it comes to children with difficulties from the autistic spectrum, the majority of the examined pediatricians correctly answered the statements that children from autistic spectrum have difficulties in development of communication, difficulties in social interactions, and repetitive behavior limited interests. Therefore, we can conclude that the examined pediatricians have a good knowledge in the field of this developmental difficulty. When the statement, that the respondents receive enough knowledge about early growth and development during the residency, a larger number of respondents partially agreed and disagreed with it, while a very small number of respondents completely agreed that they received enough knowledge about early growth and development. Therefore, it can be concluded that most of the examined pediatricians are not satisfied with the knowledge obtained at the residency. Developmental behavioral pediatrics as a field of pediatrics and its effects in childhood is still not completely known to the examined pediatricians, and almost all pediatricians agreed that this type of subspecialization should be included in our system of higher education, considering that pediatricians encounter children with difficulties at an early growth and development. But no one of the examined pediatricians affirmatively declared that in the future they would like to deal exclusively with children and adolescents with behavioral difficulties and problems. Pediatricians are in this panel and the most important members in the process of early detection and diagnosis of developmental, in this case, speech-language difficulties, and represent the most important link when referring child to speech therapy treatments. By monitoring developmental speech-language indicators and cooperating with speech therapists, psychologists, educator, rehabilitator, deviations in speech-language development in child from birth can be recognized and detected in a timely manner and therefore referred to speech therapy treatment, early intervention. Limitation of this research is the sample size, therefore similar research should be done in the future with a larger sample. The significance of this research is that based on the review on the available literature, there is not enough data on the views and knowledge of pediatricians about speech and language development. The results of the answers about the knowledge gained at the residency, the field of early growth and development, and the inclusion of VBP in the system of higher education can be used in some other research, the result of which could be sent to relevant ministers so that in some future period they could consider changing already exist plans and program of residency studies, and that more attention should be pointed to the area of early growth and development, early detection and diagnosis of deviation in developmental areas, and that each primary healthcare from available centers for early growth and development, in which pediatricians will collaborate with speech therapists, educator, rehabilitator, and psychologists, multidisciplinary action according to the needs of each child of preschool age. Thank you for your attention.
Okay, thank you very much, Dr. Samra Jusbasic, for your great presentation. Any question from audience? Any question?
Hours. We report an unusual presentation of PCH in a 53-year-old female suffering from episodes of severe sudden onset headaches that lasted several hours. The headaches were initially precipitated by coughing, as is typical with PCH, but were unusual in the way the triggers for the episodes evolved. Treatment with the beta blocker metoprolol was effective in limiting the intensity and duration of the headaches, and the symptoms resolved after 4 weeks. This case contributes towards the understanding of the potential evolution of PCH presenting with triggers unassociated with Valsalva maneuvers and ultimately occurring with no known trigger, as well as providing an example of PCH with an unusually long duration. Cough headaches are an uncommon type of head pain triggered by coughing or straining. Cough headaches are subdivided into primary and secondary cough headaches. A neuroimaging evaluation, preferably a brain MRI with and without contrast, is necessary for patients presenting with a cough headache. Once all underlying etiologies are ruled out, only then may a cough headache be considered a primary cough headache. The diagnostic criteria for PCH, also known as Valsalva maneuver headache, are described by the International Headache Society, IHS, as at least 2 sudden onset headache episodes lasting between 1 second and 2 hours, brought on only in association with coughing, straining, and/or other Valsalva maneuvers in the absence of any intracranial disorder. Primary cough headache is bilateral in distribution but can be unilateral, and the pain ranges from moderate to severe intensity, and it is described as being sharp and stabbing in quality. Primary cough headache symptoms can be debilitating, and a preventative treatment strategy should be considered. First, any pulmonary disease causing chronic coughing must be addressed. Indomethacin is a drug of choice for PCH. The possible mechanism of action for indomethacin may be that it reduces intracranial pressure. We document an unusual case of PCH presenting with triggers unassociated with Valsalva maneuvers and episodes occurring with no evident trigger over time, providing insight into the variety and possible presentations of PCH. A 53-year-old female presented to the cardiologist clinic with a splitting headache precipitated by Valsalva maneuvers. The headache was bilateral in distribution, high in intensity, and characterized by splitting or stabbing pain. The patient does not take any chronic medication nor has any past medical history of either hypertension, smoking, or drug or alcohol use. She is a teacher by profession. The attacks had started several days prior and were first triggered by coughing, defecation, and urination, all types of Valsalva maneuvers. The duration of headaches was typically about 50 minutes, and a duller, more moderate headache lasted up to 3 to 5 hours afterward. Blood pressure was recorded, which was rising to 185/105 mmHg, usually about 20 minutes after an attack. The pulse rate during the attacks was about 70 beats per minute and decreased to about 60 beats per minute 4 to 5 hours after the attack. Because of the acute onset of headaches and patient complaints, the patient was referred to a neurologist and examined. She denied any blurring of vision, facial numbness, neck pain, back pain, tingling, or numbness of the arms, dizziness, and loss of balance. In the general neurological exams, no changes were identified. To suppress the cough, the neurologist prescribed a 6-day sequence of 4 milligrams methylprednisolone tablets, starting at 6 a day for the first day, then 5 a day for the second day, dropping continuously until reaching 1 a day by the 6th day. Diagnostic neuroimaging was performed to assess for structural abnormalities and possible secondary etiologies. A brain MRI with and without contrast, magnetic resonance angiography, MRI of the brain, and a head CT were performed. All scans came back negative for structural lesions or abnormalities. This is a picture of the MRI of the brain, axial view, showing no relevant or significant changes. The MRI of the head described no hemodynamically significant stenosis or aneurysms. No vascular malformation was observed in the intracranial circulation or other relief changes. A closer look at the MRI of the head showed no hemodynamically significant stenosis, aneurysm, vascular malformation in the intracranial circulation, or other relief changes. The CT scan of the brain, axial view here, showed no relevant or significant changes. Blood work was within regular normal parameters. After the underlying pathologies of a secondary cough headache were ruled out through diagnostic neuroimaging, the patient was diagnosed to have a PCH, primary cough headache. 4 days after the diagnosis, headache triggers began to change. The patient was prescribed vitalbutal, acetaminophen, and caffeine combination capsules of 50 milligrams, 325 mg, and 40 milligrams, respectively, as needed, and indomethacin 50 milligrams thrice daily. 5 days after diagnosis, the patient was prescribed topiramate 25 milligrams twice daily due to recurring headaches. The patient was also prescribed metoprolol 25 milligrams daily, which was increased to 50 milligrams to address increased blood pressure levels. 10 days after the initial diagnosis, the headaches were precipitated by no apparent trigger. After about 2 weeks of treatment, the duration and frequency of the headaches began to decrease. By the end of the 3rd week, the patient's headaches reduced in intensity from severe to persistent moderate headache lasting throughout the day. After 2 months, hypertension resolved with blood pressure readings running at 90 mmHg to 110 millimeters mercury systolic, and metoprolol was no longer prescribed. Discussion. The etiology of primary cough headache is not clearly understood. Credenier et al. Postulate that coughing causes sudden increases in intra-abdominal and intrathoracic pressures, subsequently leading to an increase in the central venous pressure and the activation of nociceptive neurons. This case report adds more insight into the presentation, evolution, and treatment of PCH. The definition of PCH under the IHS states that headache attacks typically do not last past 2 hours. Primary cough headaches usually range from several seconds to several minutes. This case report shows a patient whose duration of headache attacks lasted for about 1 to 3 hours. There has been some documentation of cases with atypical headache durations. Chen et al. Published a series of 74 PCH patients where the median duration of a headache was 30 seconds, but was greater than 30 minutes, and up to 2 hours in about 11% of patients. Our patients' unusually extended duration of headache attacks shows that the presentation of PCH may differ, and the headache duration may be inconsistent and longer than the IHS criteria. Most noteworthy for this discussion, we found that the triggers precipitating the headache in this patient changed over time, and new triggers developed. Initially, the headaches were triggered by coughing, straining, and other Valsalva maneuvers. However, symptoms changed gradually to also include contact with cold floors and minor actions such as chewing. Even more unusually, the patient ultimately experienced headaches that appear to have no obvious trigger. This evolution of symptoms is highly unusual in the case of PCH. The definition of PCH states only that Valsalva maneuvers trigger headaches, and evolution of triggers is not included. In the literature, we have found no known cases of this type of evolution in the triggers of PCH. There are reported cases of patients whose nature of symptoms evolved, such as a change in location within the head or change in severity, but in all cases, the headaches remained associated with coughing, straining, stooping, and or other Valsalva maneuvers. Pasquale et al. Found in a comprehensive 10-year study that 100% of PCH patients experienced pain provoked by coughing, and 56% by sudden postural movements, and 22% by defecating. But in all cases, researchers did not observe pain occurring without provocation by Valsalva maneuvers. Our case report is particularly beneficial because it describes an example of a PCH patient's evolution of symptoms, providing documentation of PCH triggers shifting from Valsalva maneuvers to variable causes and ultimately having no discernible trigger. Under our broad treatment, we observed a reduction in headache frequency, duration, and intensity of pain. We found that the headache attacks decreased most in frequency and intensity after topiramate was started. In our case, PCH resolved within 4 weeks, with headaches almost disappearing by the 3rd week after the diagnosis. Therefore, this duration is consistent with the literature. Conclusion: primary cough headache is defined by sudden onset splitting headaches precipitated by Valsalva maneuvers in the absence of any underlying etiologies. We report a unique case of 53-year-old female diagnosed with PCH with symptoms of sudden onset severe headaches occurring with evolving triggers and eventually occurring without association to any Valsalva maneuvers, which is inconsistent with the IHS description. Treatment with indomethacin and topiramate lasted for 4 weeks and was found to be beneficial. The patient's PCH symptoms of severe sudden onset headaches resolved within 4 weeks, after which therapy ended. This case report adds insight into the variety of presentations of PCH and the possible evolution of triggers, as well as documentation of the unusually long duration of headache episodes. We hope that the information presented in this case report can add to the understanding of how PCH can present, evolve, and respond to different treatment medications and help guide other clinicians in their diagnostic and therapeutic process. References. Thank you for watching.
Hello everyone, my name is Juwadia Ahmed. I'm a fourth year student at the University of
Thank you very much.
Molecular and Cellular Biology and Applied Mathematics.
Kudej Ahmed and Juwaria Ahmed for your video presentation. Any question from audience?
Severe bilateral vertebral artery stenosis. The supervising physician for this report is Dr. Muhammad Habib.
I think it was finished.
Cardiologist based in San Jose, California. Vertebral artery stenosis, or VAS, is a narrowing of the vertebral artery's lumen. It presents clinically as vertebrobasilar insufficiency, or VBI. It can occur at different locations and is often due to diverse vascular pathological processes such as arterial calcification, atherosclerotic lesions, dissections, among others. The intricate and complex anatomy of the vertebral artery, as well as the varied clinical manifestations of VAS, can make it difficult to diagnose. Let's take a look at the anatomy of the vertebral artery. The vertebral artery is usually the first major branch of the subclavian artery on both sides of the body and can be anatomically divided into 4 segments, V1 through V4. The extracranial vertebral artery comprises of segments V1 through V3, while segment V4 is intracranial. VAS most commonly occurs in the V1 segment, which is also referred to as the proximal or ostial segment. The vertebral artery also supplies blood to the circle of Willis, which is vital in maintaining continuous blood flow to the brain. The variability and common occurrence of tortuosity in the vertebral artery, especially in the V1 segment, poses imaging and diagnostic challenges. Intra-arterial angiography is regarded as the current gold standard for diagnosing VAS due to its high diagnostic accuracy. However, it's also considered the riskiest, most invasive, and expensive diagnostic technique, leading to an increased utilization of non-invasive alternatives such as duplex ultrasonography, computed tomography angiography, and magnetic resonance angiography, or MRA. Within the non-invasive imaging techniques, contrast-enhanced MRA is found to be the most sensitive and specific in detecting VAS. Vertebral artery stenosis has a broad range of symptoms, including vertigo, dizziness, tinnitus, diplopia, loss of vision, and ataxia, among many others. If unmanaged, VAS may lead to severe outcomes such as cerebrovascular infarctions or strokes, vertebrobasilar insufficiency, and even sudden death. In particular, let's focus on vertigo as a symptom of VAS. Vertigo is a common clinical complaint encountered by healthcare providers and is characterized by the illusion of rotation caused by asymmetry in neural activity between the left and right vestibular nuclei. The causes of vertigo are of two broad types, peripheral and central, with over 90% of cases attributed to peripheral causes. This classification indicates dysfunction in the peripheral vestibular or central vestibular cerebellar system, respectively. The vertebral-basilar arterial system supplies blood to the brainstem, cerebellum, and peripheral labyrinths, and may become occluded due to factors such as atherosclerosis or embolism, leading to either central or peripheral vertigo, depending on the specific artery affected. Common peripheral causes of vertigo are benign positional vertigo, inflammation of the vestibular nerve, head injury, swelling of the inner ear, and certain medications such as aminoglycoside antibiotics, cisplatin, diuretics, or salicylates. Central causes are more uncommon but can be more serious. Central vertigo often originates from ischemia in the cerebellum, brainstem, or vestibular nuclei, especially in the elderly with risk factors for vascular disease. Other central causes are multiple sclerosis, medication toxicity, infection, trauma, brain tumors, migraine, and blood vessel disease. Because vertigo is more commonly due to peripheral causes than central causes, vertigo as a symptom of VAS is often difficult to recognize, as exemplified in our report, which describes a patient who presented with vertigo and was diagnosed with severe VAS almost 2 years after the initial complaint. This report is on a 71-year-old male who presented to the cardiologist's office with a range of complaints, including palpitations, leg cramps in both calves, fatigue, dizziness, and loss of balance. Several assessments were performed, including an MRI of the brain, which ruled out acute intracerebral hemorrhage or infarction. And after repeated visits to the cardiologist's office, the patient was referred to a neurologist who conducted an MRA of the neck. Both the right and left carotid arteries exhibited patent and unobstructed flow. The right vertebral artery exhibited patent status without evidence of flow-limiting stenosis, dissection, or pseudoaneurysm. However, the left vertebral artery was occluded at the origin with reconstitution of flow at approximately the level of the carotid bifurcation. Due to worsening symptoms of vertigo, the patient underwent invasive angiography, which confirmed the occlusion of the left vertebral artery and also revealed severe stenosis of the right vertebral artery. Here we see an image from the invasive angiography showing the occlusion of the left vertebral artery as well as formation of collaterals. A noteworthy aspect of this case is the relative stability exhibited by the patient despite total occlusion of the left side and high-grade stenosis of the right side. The endovascular specialists hypothesized that the formation of these collaterals, as well as normal carotid and intracerebral circulation, is likely responsible for the patient's relative stability. And here is an image of the right vertebral artery showing 80 to 90% stenosis. This case highlights that relying exclusively on non-invasive procedures such as MRA can sometimes lead to incomplete assessments. Remarkably, in this case, the MRA was able to identify only the occlusion in the left vertebral artery, while incorrectly suggesting that the right vertebral artery was entirely free of disease, despite the substantial 80 to 90% blockage, underscoring the necessity of using invasive angiography when conditions elude non-invasive methods. Furthermore, while the standard neurological evaluation as well as the subsequent MRI and MRA procedures were crucial in the diagnostic process, the cardiovascular assessment was necessary to determine the definitive diagnosis, emphasizing the importance of collaborative efforts and collective expertise in managing complex cases. In light of these findings, it is recommended patients facing similar diagnostic challenges to consider consultation with an endovascular specialist as an integral part of their clinical management. In In conclusion, this case report discusses an unusual presentation of vertebral artery stenosis with vertigo as a primary symptom, underscoring the clinical importance of recognizing that seemingly innocuous symptoms may be indicative of underlying vascular pathology. Furthermore, this case emphasizes the limitation of relying solely on non-invasive imaging for diagnosis and exemplifies the significance of interdisciplinary collaboration in diagnosing and managing atypical manifestations of complex conditions.
Okay, thank you very much to the Kudeja Ahmed and Juwairi Ahmed for your video presentation. Okay, any question from audience?
And in the next few minutes, I would like to go through this topic entitled A Golden Window, Modifying the Trajectory of Heart Cardiovascular Changes in Patients with Duchenne's Muscular Dystrophy. Now, hold on, I'm having a little technical difficulties. Just bear with me. Okay. So, Duchenne's muscular dystrophy is a chronic disease in which death from cardiac disease at an early age is one thing that is really certain. The real question is really, when will the death occur? So it's usually diagnosed following the onset of symptoms. Usually there's loss of prosody of movement. You see that parents most typically will report that the child has some delays in either walking, and then we would see typically a child that climbs up himself to stand up in what we call the classic Gower's sign. Now, following that, you progressively have progressive muscle weakness, and you have, by 12 years of age, the children have lost the ability to ambulate and are wheelchair bound. Following that, very closely, you have respiratory involvement, use of assist devices, and then death from heart failure from cardiovascular involvement. In the next few minutes, we'll explore the potential for a change in the trajectory of cardiovascular changes in these patients with Duchenne's muscular dystrophy. Going through that, we'll be looking at the distribution of the disease, the genetics, and then the research trends and the evidence-based management, which we now have for the disease. Okay. Now, Duchenne's muscular dystrophy is actually the most common muscular dystrophy present in children. Usually, every year, about 1,600 boys are affected with the disease, in a disorder that affects the dystrophin protein. And this is a protein that is produced by muscle. And in the muscle, it acts to maintain the prosody of muscle repair so that the integrity of muscles during contraction is maintained, and it mitigates muscle fiber destruction that can lead to fibrosis, atrophy, and increased muscle weakness. Now, skeletal and cardiac muscles particularly are involved, and this involvement of the skeletal muscles, of course, leads to the loss of ambulation, but the cardiac muscles that we're really focusing on in this study, in this talk, are what
is the main cause of death in the children with Duchenne's muscular dystrophy. And it leads to deaths from cardiac failure, usually in the 4th decade of life. Now, we have a problem with the Duchenne's. The thing is that although we've been able to find in the embryo somite stages where the phenotype for Duchenne's has been described, we usually don't diagnose the disease till about 5 years of age after the onset of symptoms. Now, diagnostic delays have an issue, particularly with Duchenne's, more so that a lot of studies show that in asymptomatic patients, the current therapies that we have are particularly useful. So now we're going to look at, there was an interesting case I had. It was a 2-month-old boy that came in with a pneumonia. We incidentally found that he had hypertransaminasemia. And when looking for the reason he had hypertransaminasemia, we reviewed the history. He was the only male in a family of 3. He hadn't had any other presentations that were concerning. He only had fever, cough, and rhinorrhea. There was really nothing else. His pregnancy and birth histories were normal, as well as was his newborn screen. His physical exam was reassuring, and the only thing that we saw was hypertransaminasemia. But however, despite the fact that he had this hypertransaminasemia, he had no signs of liver disease. And his ultrasonographic assessments, metabolic analysis, infectious disease markers were all within normal limits. Finally, his creatine kinase levels were investigated, just looking for a cause for his hypertransaminasemia, and it was noted that they were markedly high. This was what prompted our further investigation into a cause for his hypertransaminasemia having a muscular origin. He was finally referred to PTOT, and he was found to have Duchenne's muscular dystrophy, and he was homozygous for exon 6. Now, although this led to one of the earliest diagnoses of Duchenne's muscular dystrophy that has been recorded, the question now came about. The thing that really disconcerted us really was the fact that now that we have an early diagnosis, what next? What will be the difference in the trajectory for this child? What does it mean? What are the therapies particularly that would alter the trajectory? So now let us holistically review the current trajectory for most children. Currently, for most children, the initial presentation for non-familial DMD occurs about 3.6 years of age, following one of the caregivers observing that there are concerning symptoms. Usually there's toe walking or positive Gowers sign. These symptoms then prompt referral here in the US to occupational therapists and the development of various developmental programs. At about a year later, usually neuromuscular specialists refer them for CK analysis, and this prompts the diagnosis of the disease, usually at the age of 4.7 years. In contrast, our 2-month-old had CK levels that were performed at 4 months to uncover the hypertransaminasemia. Now, the management of Duchenne's is generally supportive. We support ambulation. They're usually wheelchair bound by 12, and we assist ventilation. Now, mechanical assist devices also are present to help with respiration. And for the cardiovascular management, we usually use ACE inhibitors, beta blockers, and ERBs to prevent the cardiovascular disease that culminates in death. Now, we'll focus on the developing therapies that are geared towards the most common cause of the death in children with Duchenne's, which is the cardiac disease. Now, the Deficiency of dystrophin manifests as cardiomyopathy in the heart. The progressive fibrosis of the myocardium leads initially to asymptomatic cardiomyopathy, but then later, as they are symptomatic with cardiac failure, we have dilatation of the heart and then life-threatening arrhythmias. Previously, due to our reliance on just the signs and symptoms of Duchenne's muscular dystrophy, we usually diagnosed the children late and instituted the management late. However, currently, if diagnosed early, they can be monitored early with more recent monitoring devices, something like the cardiac magnetic resonance imaging, and we have the gadolinium contrast enhancement. And what this does, it allows us to very early detect that we have myocardial fibrosis and institute treatment. In Duchenne's, we also have dilatations that could lead to left ventricular strain patterns and abnormalities with contractility. Using the cardiomagnetic resonance imaging, these can be picked up early. Now, looking at cardioprotective therapies like the eplerenone is currently under trial. The drug has been demonstrated to show improvement with the left ventricular strain patterns that reflect how well the heart is contracting when it is used prior to the onset of left ventricular failure. In a study, they found that the children that were younger, 7 years old and younger, actually showed an improvement in their left ventricular strain pattern, while the older children just found a stabilization in the decline of their left ventricular strain patterns and their cardiovascular disease. So it was really demonstrating that the earlier these drugs are started before symptom management actually optimizes the function of the drug. Now, we also use things like corticosteroids, and these help for respiratory as well as improvement of cardiovascular decline. Myostatin inhibitors are also some of the things that are currently being looked into. And what they do is they inhibit there's a protein that inhibits muscle growth. And this is present in patients with Duchenne's muscular dystrophy. So they're looking at the presence of myostatin inhibitors, use of myostatin inhibitors to improve the loss of cardiovascular decline. Now, elevated levels of muscle wasting are actually seen from the myostatin in patients with Duchenne's. Another therapy that is being looked at is also utrophin. And for utrophin gene expression, we're looking at ways of upregulating utrophin gene expression because it has a function similar to dystrophin and is actually present within the muscles, normally present within the muscles. Now, those studies that are actually geared towards utrophin upregulation show an increased expression of utrophin in muscle cells that are when muscle cells have more levels of atrophin rather than they have a lot of fibrosis. Now, approval for drugs, the use of all these drugs in patients with dystrophin, with Duchenne's muscular dystrophy, is actually limited by the availability of children for clinical trials. Early diagnosis and early inclusion of patients, such as our patient, in dystrophin registries can potentially harness patient selection for these trials. Dystrophin restorative therapies with amino acids and peptides are also being explored, but we do really need patients to be available for selection for these trials to facilitate their approval for use for the general population. Now, the use of restorative therapies such as gentamicin for the stop codon read-through revealed that increased dystrophin actually, after gentamicin therapy in patients with higher pretreatment levels of dystrophin, supports the fact that the earlier you treat the patient, the better the outcomes. In conjunction with animal studies, we found an age-dependent decline in dystrophin levels, which suggests the utility in younger patients. Now we have FDA approval of two drugs, enterprising and goldserine, for those with exon 51 and 53 skipping therapy. Although this is really a restrictive inclusion, but it is still something that is helpful for these patients. There was really a interesting breakthrough this August. The first ever gene therapy was approved for Duchenne's muscular dystrophy, and that was the drug Elevidys. And now Elevidys is indicated for patients that are 4 through 5 years and are still ambulatory. And there are certain genetic variations that are contraindicated for its use. Those ones are associated with immunologic reactions when they're used with in patients with Elevidys. So recombinant gene therapy is designed to deliver the Elevidys microdystrophin protein. And this protein is a modified version of the dystrophin protein that is deficient in Duchenne's. Now, the EMBARK trial that was actually instrumental in the approval of Elevidys had the inclusion criteria of ambulatory children that were greater than 4 years and less than 8 years at the time of randomization. This, of course, reflects the current inclusion of children for the drugs, is 4 to 5 years, which was the population studied. And it's interesting that the age of 4 years corresponds to the mean age at which Duchenne's is actually diagnosed. Now, although our patient is less than 4 years, the EMBARK trial and the accelerated FDA approval of Elevidys, it actually underscores the value of an early diagnosis in enabling the prompt identification of eligible patients, not only for current treatment options, but also for enrollment in trials. Now, looking at this early diagnosis, the newborn screen presents really a logical means of early diagnosis of patients with Duchenne's muscular dystrophy. This is more so since we have already seen that even in the embryo, we've seen abnormal phenotypes of the dystrophy. Now, in the early 1970s, there was a lot of discussion about the inclusion of Duchenne's muscular dystrophy screening in the newborn screen for so many different countries. However, at that time, there was an absence of validated simple screening tests and early treatment interventions that could be instituted. So most newborn screening programs for Duchenne muscular dystrophy were discontinued. Here in the US, we do not screen for Duchenne's muscular dystrophy in the universal newborn screening path. However, since 2019, we actually have FDA approval of kits that can be incorporated for Duchenne muscular dystrophy screening during the newborn screen. Focusing on the decline in heart muscle function, which is the leading cause of death in patients with Duchenne's muscular dystrophy, studies have indicated that the initiation of various therapies prior to the onset of symptoms in patients with Duchenne's has the benefit of delaying the onset of decline of cardiac muscle functioning in these patients. Thus, the use of newborn screen for the establishment of diagnosis of Duchenne's muscular dystrophy at the earliest possible juncture is of increased relevance today. Now, Duchenne's muscular dystrophy is asymptomatic in its earliest presentation. Studies demonstrating the current evolving therapies have greater efficacy when instituted prior to the onset of symptoms. Unfortunately, our high reliance on physical symptoms.
This is the last presenter.
Hello?
Presentation. Tulisannya itu presentation. Kue mana teksku?
Unfortunately, the reliance on physical symptoms and chemical aberrations has led to diagnostic delays. However, the inclusion of CK analysis can eliminate multiple sources of diagnostic delays. In the light of our current knowledge, the value of an early diagnosis of this disease cannot be overemphasized. Early diagnosis can assist us in understanding the natural history and delineating the most vital time for our earliest intervention. Early diagnosis can facilitate patient selection and enrollment trials vital to DMD trials. Early diagnosis is important in instituting and monitoring patients with Duchenne's muscular dystrophy and giving the guidance the parents require. Now, early diagnosis is important to ensure no opportunities are missed to harness the current trends of care that are so vital and have the potential to delay the onset and change the trajectory of the leading cause of death in patients with Duchenne's muscular dystrophy, which is end-stage cardiac disease. It is up to us all to raise awareness and advocate for the early diagnosis of every child with Duchenne's muscular dystrophy. Thank you. Any questions, please?
Okay. Thank you very much to the Dr. Uziago for your great presentation. Okay, now.
Doesn't work? Yeah. Okay, very shortly, because there is a limit of time, I won't go through all the slides, but I will emphasize some basic elementary things about this model. Please go on. The next slide. Yeah, so in my presentation, I connect the analysis of an organization's operations to business excellence as the ideal to which all good organizations aspire. So excellent organizations achieve and sustainably maintain the excellent levels of operations that meet or even exceed the expectations of all other stakeholders. So if organizations are to realize to what extent they are business excellent, or how far removed they are from this desired goal, they must approach the analysis of their business comprehensively. Please go on. We go fast, please. Follow me, fast. So business analysis begins with the observation of facts, with diagnosing problems, and continues with setting up hypotheses and their logical and practical testings. So this also implies the definition of measures to improve operations, which leads the management of the organizations to the planning of the organization's operation. Please go on. So I will limit, okay, there are several criteria. I will skip some of them. I would just like to make it easier to understand the approach to business excellence analysis and clarify the analysis of the business excellence of a certain business system. So let me choose then some organization, hospital, clinic from the field of healthcare. Go on, please. So let me start first to clarify what difference there is between total quality management and business excellence. We start with Aristotle, who wrote that excellence is not an individual act, but it is an attitude. Excellence is much more than performance if we look at it as a characteristics of an organization that achieves the desired expected results. A legal entity that surpasses, exceeds others in terms of quality is excellent. When judging the excellence of an organization, it's necessary to start from the point of view of others. So how they perceive us, how they look at, how they feel us. And while quality means the fulfillment of customer requirements and expectations, business excellence means exceptionality, means exceeding the expectations of all interested parties, stakeholders like employees, customers, etc. Go on, please. Today, we demand quality at every step of the way. So we no longer understand it only as compliance with specification requirements, but as an excellent performance that increases customer satisfaction. Or excellence is not a theory. It is about the tangible achievements of what the organization does and how it does. The results achieved and the belief that it will sustainably achieve such results also in the future. So in order to inspire confidence in the sustainability of results, evidence is also needed. And it needed that what the organization does and how it does, it is well designed, systematic, and constantly reviewed, and of course improved at the end of the day. Go on, please. Excellence can be defined as exceeding the average and finding the best possible results. Excellence is not just about the choice of one model or another. It implies a conscious decision to work perfectly every day. Now I come to European Foundation for Quality in Brussels, which defines excellence as the excellent practice of managing an organization and achieving results based on fundamental principles. And what are these principles? Let us go very fast through these principles. Next slide. Adding value to customers, creating a sustainable future, developing organizational skills, encouraging creativity and innovation, leading with vision, inspiration, and integrity, agile management, achieving success with the talent of employees, and sustainable achievement of excellent results. Go on, please. So several awards for quality and excellence based on models of excellence have been established globally. So everybody knows Deming Award in Japan, Malcolm Baldrige Award in the States, European Award for Excellence in Europe. So all three awards are based on a prescribed protocol of systematic elements of assessment, self-assessment, external assessment, and finally on final value assessment. So the greatest advantage of the model of business excellence are European comparable business evaluations, which deal with all key areas. Go on, please. More than 25 national quality and excellent awards operate in Europe based on the FQM excellence model. There in the world, there are a total more than 77 national awards for quality and business excellence, more in 69 countries. Okay, go on. The main objective of both the European and other national awards for quality and excellence is to raise efficiency and effectiveness at the national level. And in Europe, the most widespread and used model is the EFQM excellence model. It constitutes a comprehensive management framework used by more than 30,000 organizations all over Europe. Go on, please. The FQM model emphasizes, please move up a little bit the slide. Or I don't see it, just a second. Next slide, please. Yeah. So the FQM model emphasizes customer primacy, the need for a long-term stakeholder. The structure of this model is based on three simple but very compelling questions. First, why does the organization exist at all? What is its purpose? Why does it use a certain strategy? Second, How does it plan to fulfill its purpose and implement its strategy? And third, what has it actually achieved so far? And what does it intend to achieve in the future? So here we speak about the orientation, about the implementation, and about the results. Please move on. So the basis of the logic of this model pertains to the connection between the organization's purpose and strategy, and how this is used to create sustainable value for its most important stakeholders and to achieve exceptional results. Organizations are also obliged, to take care of the ecosystem in which they operate. This ecosystem consists of economic, environmental, and social conditions. Move on, please. Now here we have the structure, the model, the structure of the model. We speak of 7 measures. Like we have, first of all, just explained, direction, execution, and results, or implementation and results. And then we have around these 7 satellites, right? These are called measures. There are 7 measures, but the whole model consists of 35 sub-measures. We do not have time, to present the whole model, just to get an overall picture of it, of what elements, of what measures it consists of. Please go on. So the use of the business excellence model constitutes a comprehensive systemic approach to management, as it basically enables a relatively objective analysis of the situation. So the identification of weak areas in the organization's operation and continues with improvements, so based on the information obtained. Okay, just go on. We will skip some text here, not necessary. Just analysis. Just go on, please. Go on. Go on, please. Yes, model. Go on. Yeah, okay, stay here, please. Radar Metrics is one very useful tool which is used by this FQM model. So all the highest level, the radar logic, radar is the acronym. Radar stands for like R for research, A for approach, D deployment, A assessment, and R review. And that an organization must what? Determine the results it wants to achieve as part of its strategy. Second, have several approaches with which to achieve the desired results now and in the future. Third, implement and deploy these approaches in an appropriate manner. And last but not least, assess and refine the introduced approaches in order to learn and improve. Let us see a diagram in the next slide, please. Yeah, you see. So, develop the approaches. Then second, systematically deploy them. Then assess the results and define the results. And okay, correct and refine them. Please go on. Just to get an idea, because we do not have time to go into detail, here you have an analysis of direction, because again, the model consists of direction, of execution or implementation, and results, right? And here we have analysis of direction. We have approach here, deployment and assessment and refinement. And then you have some attributes, like approach have the following attributes. It can be sound, can be aligned. Deployment, implemented and flexible as attribute. Assessment and refinement, so evaluation, understanding, learn, and improve. And on the right side, you have description of these individual attributes. It is very similar done for the execution and also for the results. We do not have time For this reason, please go on. Move on. Just go on. You can see this by yourself if this material will be distributed. Just go on, please. I would like come to the healthcare. Just go on. Yeah. Yeah. Okay. Let us continue with this slide. So I would like to make some emphasis using this FQM model in a special area like healthcare organization, because this is a scientific conference on global healthcare, and I would like to give my contribution with this model, particularly to this area. So let me continue with the following. So the business excellence of healthcare organizations, this can be hospitals, clinics, etc., can be analyzed with a series of indicators, such as the length of waiting times, the length of hospital stays, so how many number of days, the number of less invasive interventions, the number of complications, nosocomial infections, then patient falls, etc. There are a lot of, or many others, but I have just taken some of them from, application of one medical center which took part in this business excellence assessment. So the business excellence of healthcare organizations is manifested in particular through the prism of the quality of healthcare services, surely. So we can describe them, I mean, the quality of these services with quite a few of attributes. But first of all, we need to know who are the key stakeholders in healthcare. These are the medical staff, patients, and health insurance companies, healthcare payers. Please move on. Next slide, please. Yeah, so all of them, all of these stakeholders, attach different degrees of importance to individual attributes, which is why they also define the quality of healthcare services differently, as shown in the table below. Just I would like to take your attention to this table below, where you have on left side key stakeholders, so medical staff like doctors, then patients and payers, healthcare institutions. So then we have some attributes. These attributes are like technical achievements, interpersonal relationships, convenience and access, patients' wishes, efficiency and cost efficiency. And here in this table, you have drawn, several pluses, or like, for example, what does it mean? The more pluses, the bigger importance to individual attribute. Like doctors, they pay a lot of attention and are very much interested in technical achievements, in modern technology, robots, etc. What is not the case, for the payer. The payer is mostly interested in efficiency and cost efficiency, because he pays these services and he wants, that these services are perfect, realized, and that they are also cost effective. And if we look at the patient is more or less, interested in his patient's wishes, etc. Let us go on. This now becomes very interesting because it is an economic aspect to these services. So let us take a brief look at the attributes that were defined many years ago by very renowned experts in this area, like Donna Bedian, Castle, and Arrow, and are still used to define the quality of healthcare services today, but are at the same time evaluated on the basis of and measure the business excellence of healthcare organizations in the eyes of the customers of such services. So the customers are, in this case, patients mainly, and also the payers. So the quality of technical achievements, so exploitation of the medical profession, that's the first. The second, managing interpersonal relationship, especially between doctor and patient. Then third, quality of treatment, comfort, and access to treatment, especially interesting for patients. Then patients' wishes and preferences, and treatment effectiveness, dealing mainly interesting mainly, you know, for the payers of these services, and cost effectiveness. Please move on. Just a couple slides and we finish. So by efficiency, we mean how well resources are utilized to achieve the planned result. So efficiency always improves when the resources used to produce a given output decrease. So as ineffective treatment consumes more resources than it should, so it is wasteful. Treatment that is wasteful is deficient, incomplete, and therefore of poorer quality, no matter how good it is in other respects. Or as Donna Bedian in 1988 put it, wasteful treatment either harms health or is harmful to it because it prevents more beneficial treatment. Move on, please. Cost effectiveness of concrete health services, such as surgery, may be, according to these experts just mentioned before, defined by how much benefit such a medical intervention brings with a certain extent of expenditure, which is typically measured in improvements of the health condition. So in general, as the amounts spent to provide services under certain conditions increase, returns begin to decline. So each additional unit of expenditure yields so-called diminishing benefits. This is economic aspect, until a point is reached where further increases in the inputs to treatment result in no benefits. It's a very, how would say, a tough statement, but it is a statement, you know, from the aspect of the economic aspect. So the idea that resources should be used to the limit as long as benefits are still flowing has been accepted as a maximalist aspect of quality treatment. In this respect, the elements can be consumed as long as there are benefits, regardless of their size. So a maximalist aspect. On the other hand, we have, please go on, we have another aspect, optimal aspect, which says what? Please move on. Yeah, as an alternative to this maximalist idea, an idea was developed on the optimal aspect, which says what? Which states, you know, that spending should stop earlier at the point where the additional benefits are too small to be worth the extra cost. This is a very tough, I would say, very inhumanic, not human aspect, you know. So it means if we look, you know, from the economic point of view, we will invest, you know, or spend money so much or buying inputs and so on until we have the benefits, but the bigger benefits, when the benefits become equal to input, to costs, you know, to spending, then we stop. Doesn't matter what the consequences are. This is, I would say, not acceptable, you know, for healthcare. But it is, I mean, it's good to know that there is a principle like that, like a marginal aspect, like economics look at it. So in my written contribution, I have presented the effectiveness of operation of healthcare organizations according to the following attributes that are here. Okay, I will stop here. There are some other slides where I give my critical assessment, how this radar matrix, you know, is not well exploited, used by assessing. That the assessor, when they assess, you know, the organizations, the companies, etc., they should rely much more on this radar matrix because it helps us a lot Please move on. I will just finish with one slide. Please go on. Yeah, we will stay here with this, you know. One slide more, please. One further, please. One slide more. Move on. No. Go back, please. Go back. Go back. We start with approach and the results. So deployment, how it is deployed within the company or even externally. And to what extent are the results checked and measured? This is very important for the strategy implementation. And last but not least, what are the strategic goals and how does the organization achieve them? These are the crucial things and crucial elements that Radar Metrics, you know, offers us and help us to assess an organization. Thank you very much for your attention. If anybody is interested in this model much more, can read my paper that I also sent to the organization. Thank you. If there are any questions, I will be pleased to answer. Okay, if not, thank you for your attention.
Patient and type 1 diabetes, which were 15% of our patients. We implemented basically the continuous glucose monitoring instead of self-monitoring blood glucose 4 or more times a day in patients who are on 3 or more injections of insulin per day, plus minus anti-diabetic peroral medication or GLP-1 receptor agonist. My name is Professor Dr. Andrei Manov. I'm professor in the University of Las Vegas, Nevada, and I'm program director of transitional year residency in Mountain View Hospital, Las Vegas, Nevada. I'm board certified endocrinologist as well as internist in United States as well as in European Union. Basically, what I want to mention that in United States, above 34 million people have diabetes mellitus, and 90% of them are with type 2, and 10% have type 1 diabetes mellitus. Usually, diabetes mellitus affects older individuals with type 2, but we see now more and more type 1 diabetes mellitus, which happens also in an older population. It's increasing as well. It's a leading cause, diabetes mellitus is a leading cause of amputation, non-traumatic, of the extremities, usually lower extremities, of blindness, and end-stage renal disease. Because the diabetes mellitus is a chronic disease, we need to monitor the blood glucose 24 hours a day with a device like the continuous glucose monitoring, rather than self-monitor blood glucose only 4 times a day, which basically gives us the opportunity to see the whole picture of the glucose variability throughout the day and night, rather than only at 4 points at a time. So because of this is a chronic disease and needs continuous monitoring and management, continuous glucose monitoring is compared to self-monitoring blood glucose is like having a map in a place which you don't know where you will end. That's how we can compare it. With self-monitoring blood glucose, we use a reactive approach. We see blood sugar is high, we increase the insulin, while here with continuous glucose monitoring, we can have the proactive approach and do the changes in the lifestyle of the patient or in the insulin regime of the patient proactively. it has been shown in studies which started in the last 10 to 15 years that first they started in type 1 diabetes and then they were confirmed in type 2 diabetes. It decreases the glucose management indicator, which is based on average blood glucose and is comparable to hemoglobin A1C without having the shortcomings of hemoglobin A1C, meaning that it is not accurate in patients with anemia, chronic kidney disease, cirrhosis of the liver, among others. Hemoglobin A1C is not correct in this type of situation, while glucose management indicator is correct and is based on average blood glucose. And the other things which we are looking is time in range, which is the most important basically indicator of glucose control. Time in range means how long we can stay between 70 and 180 throughout the day, and the American Diabetes Association goal is to be above 70% of the time. Also, we were looking at basically time above range, meaning the blood sugar which is above 180 to 250, which we call it high, to be less than 25% was our goal, and very high above 250 to be less than 5%, but also to avoid the low blood sugar, less than 70 to less than 4% of the time of the day, and less than 1%, less than 54. Also, we were looking at coefficient of variation. We know that variation of the blood glucose throughout the day is associated with diabetic complications to be less than 36% of the time, coefficient of variation. And we use also standardized questionnaire to see if the patients who were on self-monitoring blood glucose and were switched to continuous glucose monitoring, which is now a standard of care in patients with type 1 and type 2 diabetes mellitus, basically are happy with this switch. So basically, what we are proud to say with this study is that for the first time in this retrospective study of 25 patients between age of 42 and 75, as I mentioned, 85% were with type 2 and 50% were with type 1 diabetes mellitus. Basically, the monitoring of the blood sugar, adjustment of the insulin, of the food intake was done not in specialized endocrine clinic by endocrine specialists, but by the trained internal medicine and transitional year residents under the supervision of board-certified endocrinologists, which was me. They were always able to reach out to me and ask me if they have any specific question. But majority of the time, they were making the changes in the insulin regime. The internal medicine transitional residents were doing this on my own after, of course, education, which I did to the whole group of basically of the patients. We recruited, there were recruiting 25 patients starting from 2021 to beginning of 2023, as I mentioned, which were absolutely uncontrolled on 3 or 4 injections of insulin per day, and they were self-monitoring blood glucose 3 to 4 times a day. They were basically, this is in our methods, they were between 18 and 80 years of age with type 1 and type 2 diabetes, and their A1C was above 7%. They were uncontrolled or after self-monitoring blood glucose 3 to 4 times a day. And patients received primary care treatment only in our clinic, and we included the patients who were able to understand the continuous glucose monitoring device. and we included only patients who were on 3 or 4 injections of insulin per day. And the data we evaluated was the change in the A1C after switching from self-monitoring blood glucose to continuous glucose monitoring. Also, the change in the average blood glucose, as well as the time in range, as well as the percentage of time spent by the patient after the switch in mild hypoglycemia or more severe hypoglycemia. Quality of life questionnaire the patient was asked after the switch, and a change in the patient medication was done. The results were really very good, and the reason for these excellent results compared to other randomized or observational studies was that our population was very indigent. We had 30 to 40% Medicaid patients with poor understanding of the diabetes, which our residents were basically able to bridge this gap of the knowledge by explaining to the patients the nature of the disease, the nature of the glucose variation, the nature of the adjustment needs to be done in their diet and in their insulin regime. And everything was done under the supervision of board-certified endocrinologists. The starting point of hemoglobin A1C, which the patient had, was 11.21%, and the average blood glucose while the patient was self-monitoring blood glucose 4 times a day was 286 milligrams per deciliter, and the patient was spending on average 1 hour and 14 minutes in mild hypoglycemia and 29 minutes in more severe hypoglycemia, less than 54, before the switch. Also, the variation of the blood glucose throughout the day was pretty high before the switch to continuous glucose monitoring, basically was 39%. And the goal by American Diabetes Association is 36%. We were seeing the patient in the clinic only, physically, monthly, and the residents and or me were calling the patients usually twice a week to acquire information about the patient's glucose variations, the reasons for these glucose variations, and to adjust the patient's diet, to adjust the patient's physical exercise, and to adjust the patient insulin and other anti-diabetic drugs. This was our retrospective study, which lasted approximately 2 years. And at the end, we were very proud to say that with the major participation of the residents in non-specialized endocrine clinic, but in residency continuity internal medicine clinic run by internal medicine residents and transitional residents, we were able to decrease the hemoglobin A1C from 11.2 to 7.04, so approximately 4% we decrease hemoglobin A1C. Like I mentioned, in other trials, the decrement was approximately 0.5%, but because of the population we treated, we had much better, as I mentioned, results. The time in range between 70 and 180 increased from 18% while the patient was self-monitoring their blood glucose to basically 74% while using the CGM, which was surpassing the ADA goal of 70%. We know the time in range is associated with microangiopathy, especially with diabetic retinopathy and nephropathy, which the studies basically showed. The coefficient of variation, which is also associated with micro and macrovascular complication, decreased to 29%, or while the patient was using continuous glucose monitoring, from 39% while the patient was self-monitoring their blood glucose. The low blood sugar basically decreased in our study to basically decrease in our study significantly. And the patients had 11 minutes spent in blood from 1 hour and 14 minutes spent a day with blood sugar less than 70 milligram %, and from 29 minutes in severe hypoglycemia per day, which was basically on self-monitoring blood glucose. It decreased to basically 3 minutes per day. Both these values were below the ADA goals of mild or more severe hypoglycemia goal. So the hypoglycemia goal we achieved with continuous glucose monitoring was approximately 3% a day, and the ADA goal was less than 4%, and severe hypoglycemia goal was less than 1%, and we achieved 0.2% after the switch to continuous glucose monitoring. The average blood glucose basically decreased from 286 to 254 up to 154, which was significant improvement in the average basically blood glucose as well. 4 of the patients were able to stop their insulin and to continue on peroral anti-diabetic medication plus minus once a week GLP-1 receptor basically agonist. On the patient quality of life questionnaire, 100% of the patient were very happy with the switch, which we attribute to the better glycemic control, healthier lifestyle, improved physical activity, improved basically eating patterns, which the patient basically did after the switch. So basically what we can mention is that technological advances have significantly impacted diabetes mellitus in the last basically 20 years. One of these technological advancements is the continuous glucose monitoring, which we believe is the major and the most important technological advance because it gives us the whole picture as a movie of the variation of the blood glucose throughout the day and night of the patients. With its usage, we were able to significantly improve the glucose control in our patients. We were able to demonstrate that this improvement of the glucose control, decrementing A1C from 11.2 while self-monitoring blood glucose to 7, 11.2 to 7 with 4%, by decreasing the average blood glucose from 280s to 150s, by improving the glucose basically variability from 39% to 29%, by decreasing the high blood sugar from 4.75% to 3%, by decreasing the very high blood sugar to only 0.2% while using CGM, and decreasing the low blood sugar below 70 to less than 4% and less than 1% very low blood sugar less than 54, and improve the patient satisfaction. We were able to show that this can be done not in any specialized endocrine clinic, but in internal medicine residency clinic, and that way improve 2 things. First, the quality of care of our diabetes patients, and second, the quality of education of our internal medicine and transitional residents, because and transitional residents. As we know, continuous glucose monitoring is the future, and we believe that in 10 years, majority of the patients with diabetes will be on continuous glucose monitoring, especially the patients who are basically having significant variability of their sugar, who have significant hypoglycemia, who have diabetic gastroparesis, who have Down phenomenon, who has very difficult to treat hyperglycemia with significant insulin resistance, among others. We are proud to say that we, as far as we know, we are the first internal medicine residency clinic in the United States in which this was implementing the continuous glucose monitoring by internal medicine residents. The project was basically managed primarily by the internal medicine residents after education and with ability to consult the board certified endocrinologist. And we think that what we have achieved can be implemented in other internal medicine residency clinic in the United States, as well as throughout the world, as a teaching device, as well as improving the quality of care of our diabetic patient to decrease the risk of micro and macrovascular complications and decrease these unfortunate facts that diabetes is number one cause of non-traumatic limb amputation, blindness, and end-stage renal disease. Thank you.
Change their life. So I'm going to go through this today. So here's the overview. The week one looks at our trapped, stuck cycles that we're in, our patterns and loops. The week two of the program looks at identity structure. Week three looks at becoming your own generator of the emotions you want to experience. Week four looks to turn painful things into strengths and positives. Week five relates to taking responsibility for your own happiness. Week six is living and loving our life and ourselves on purpose. And I have another section about beyond the program, sustainable practices you can do every day that are really easy and take 1 minute to help maintain what you've worked on as well as even improve it. And then at the end, instructor training information, a little bit of an overview on that as well. So there are different components of the program that I've created. Here is the emotion chart, and there is the red zone, destructive emotions that we often get trapped in. The green zone, relief emotions, or it's kind of like positive-ish, but mostly it's that you got to a point of relief from the negative. And then the uplifting and lightening emotions, these lift you out of the red zone emotions, and they help you to improve your life in a lot of different ways. And I call those the blue zone emotions. Other components of the program include the weekly meetings and hypnotherapy meditation recordings. So there is a weekly Zoom meeting. There's a initial introduction one, and then there is one each week. So the introduction one gives an overview, what they can expect, and sort of an overlay of everything. And then the last week touches upon sustainable approaches and carrying this away beyond the program. There are 21 different pre-recorded hypnotherapy meditations I've created, and these are all part of the program as well. All 21 are accessible. There's different topics depending on what resonates with someone and what they need the most support with. I've just seen in my therapy practice that the topics of safety and self-worth and sleep seem to be some of the most important ones. But yeah, there's a whole variety of different hypnotherapy meditation recordings that you can listen to when you are in the hypnagogic state. So when you're kind of sleepy is a good time to listen. And that really deals with the subconscious patterns and loops that we get stuck in. There's also the daily activities and self-reporting. So this piece is it is a 6-week program, but there is something to do every day to help yourself and support yourself in this program. Another component of the program is I created a adjusted or adapted rational emotive behavior therapy, or REBT, exercise. Why did I do this? I did this because our beliefs matter, and the original REBT I find to be a bit more complicated, and I wanted something that people could just get into almost like an automated mode and just do this easily in their head at some point, and just be able to more simply adjust beliefs and look at things from different perspectives. So what I did was you have your negative identified belief, and an example might be something like there's no reason to be happy. And then you look at, well, what is the benefit of this belief? Is there any benefit? And the benefit might be, for example, well, I get more attention from my family and others when I feel sad. So kind of the victim mentality. What is the harm of this negative belief? Feeling bad, not helping mood, or wanting to stay sober for this particular example. So the first piece is that identifying the negative belief. Second piece is identifying what benefit you get. Third is what is the harm. And then looking at alternatives, so positive alternatives. So, for example, there's at least one reason to be happy. Eventually, there could be a reason to be happy. I'm mostly just hurting myself with this belief. And another piece to this is to ask yourself how true it seems. So if, like, let's say there's no reason to be happy, that feels 10 out of 10 true. So you ask yourself 1 out of 10, how true does this feel? Does this feel like a fact? Because these are not facts, these are beliefs. And then with the alternatives, asking yourself, okay, well, how true does this feel? There's at least one reason to be happy. That might feel a little bit true, so maybe 3 out of 10. But it can help you to understand, oh, are these facts or are these beliefs? Another component of the program that I created is the identity circle. So the breakdown of it essentially is that in a lot of ways, we on some level are a bit like a computer with software programs downloaded. We don't exactly know, but we think there's tens of thousands of thoughts a day, and the vast majority are subconscious. We think like 85, 90% are subconscious. And we think the vast majority are similar or same thoughts as the day before, which means we're running almost on like an autopilot. But where do these beliefs, values, patterns come from? Well, they come from family, religion, relationships, culture, society. So we're, exposed to tens of thousands of advertisements. I don't know if it's a day or week, but we're exposed to a lot of things that we don't even notice. So this creates equals what we see as ourself. And this can be really important for happiness and mindfulness because it helps to break down, like, okay, what are some family patterns, values, and beliefs? What are some educational ones? What are some relationship ones? What are some religious ones? Like, you're basically looking at your programming in a detached way and then asking, do I like these? Are these good for me? Are they harmful for me or others? What do I want to change? And what do I want to keep? And then within that is looking at, okay, well, what is the self? And the self here is the observer and the experiencer of these different programs, consciousness. So yeah, this was a way of conceptualizing it and breaking it down. And some of the ones that are, I put family and relationship closest to self because those can be some of the hardest to untangle. And they can seem the most like yourself. Okay, another component of the program is track cycles. And so something I see over and over is people being trapped or stuck in loops, the same patterns over and over again. So I created this chart to help comprehend it in another way. So number one, I put pure awareness. You could think of that as the self. That's the consciousness. And then when you add in some kind of belief, perspective. So for example, let's say you have a belief that, I don't know, you have to go to college or something to be successful. So that's a pretty mellow belief. But let's say you are just the experiencer and you picked up this belief from a combination of family, relationships, school, society. And then that created the perception, judgment, thought that there's something less about you or not as good if you don't go to college, or something more about you or okay if you do. And then the reaction could be anxiety about going, or, you know, delusional positive thinking about going. And then the corresponding state that you are stuck in, going over and over. So let's say it's anxiety about not going. And then you might just look around and think over and over. And this is based off of a client I saw today that I was thinking about. So it's the belief or lens. And what if you change that belief that, okay, well, what does success mean to you? How do you define that? Is it possible to be successful in different components or different ways, different mechanisms? So we get stuck in loops and we don't even know it. And we think that's just who we are, what we're experiencing. And it can also just be programming and trying to manage ourselves in the world. Okay, another component of the program is the present. So looking at the present or somewhere else. So asking yourself, am I here in the moment? Is it, you know, am I, no past, no future, just like I just arrived here. Am I here right now? Or is my mind and my energy being pulled towards the future, the past, imaginary issues? Where is my attention going? And that's also very important for the mindful happiness piece of this, that you have to first notice where your mind is at in order to help rein it back in. And you could also say where your energy's at, where your focus is at, where your feelings are at. So instead of reacting and being sucked into it, you are noticing where it's going. Okay, so you might be wondering, how is this unique? How is the happiness-based mindfulness program I've created different from other things out there? So I'm trained in the Mindful Self-Compassion Program, Mindfulness-Based Stress Reduction, and Mindfulness-Based Cognitive Therapy through UC San Diego. And I also taught the Mindfulness-Based Cognitive Therapy for NYU for 2 years remotely. So I do have a good foundation in these things, but this is different. This is different because this really does focus on our happiness and really practical tools that are a lot of them unique and I have not come across in other places, but I see over and over again with clients. And so I created it to address what I saw as a gap in psychoeducation and mindfulness curriculum. So it addresses components that are largely non-existent in many other forms of therapy and psychoeducation. So some unique components to this is that we're focusing on identity and what our identity, what it is, are trapped and repeating cycles. There is the use of regular self-rating. We know that what we measure, we improve. So regular self-rating will help bring awareness, detachment, and improvement. There's an emphasis on service. Giving, kindness, intentional act of kindness and service are actually important for happiness and mindfulness because it helps us get out of our head and we are giving to another, and it helps us to generate positive emotions. So this is a piece that I find largely lacking in a lot of therapy, psychology, and mindfulness interventions. We are not islands unto ourselves. We live in systems. So the importance of the subconscious, which is huge. I have not seen this addressed in a lot of psychoeducation programs or mindfulness programs. In a lot of ways, you could argue that the subconscious, we think, kind of runs our life. And so we can consciously know not to do certain things, but we can't seem to get ourselves out of our own way. The red, green, blue zone emotion chart. It's another way to self-rate and have detachment. But I've seen really cool stuff with that. When I've used it with clients, I've seen a lot of positive changes. And it's something you can easily do on your own at home. The alchemization or changing of red zone emotions, being your own emotion generator. So instead of looking to the outside to make things better, like how can you cultivate more of certain emotions on the inside? Taking self-responsibility for your happiness. Something I come across, and it's a bit tricky, is people having something happen to them that is very painful. And you could argue they are a victim in that moment of whatever happened, but then taking on the victim mentality and becoming unknowingly self-centered or not taking accountability and responsibility for their situation, essentially disempowering themselves. So you get stuck in the victim state, and that's a really good way to be unhappy and unconscious. And then also, another piece to this is the self-love chart that I have at the end for sustainable intervention. The HBMP provides a format of psychoeducation that can be used. It can be used in group therapy, online or in person. It can be used to support individual therapy, to provide psychoeducation, learn new skills that can be applied in all kinds of settings, to enhance your mindfulness practice and enhance your well-being regardless of your outside situation. Okay, so I will briefly go through each week. So week 1 is looking at your patterns and loops. So we have tens of thousands of thoughts a day. It's estimated that 85 to 90% are unconscious and 90 to 95% are the same or very similar as the day before. So this means that in many ways we are on autopilot or repeat. Without awareness, we tend to stay on repeat like a software program full of ongoing codes. So these patterns can cause us pleasure or pain and attachment to stories, as well as challenges. So we tend to like being attached to what's familiar, even if it's harmful for us or toxic. So just a simple act of bringing awareness and identifying these patterns, loops, habits, and thought structures helps interrupt these loops. And a majority of people spend most of their waking consciousness in an area I call the red zone, which is on that emotion chart. You can also call it the destructive emotion zone. These are emotions like shame, apathy, helplessness, blame, fear, resentment, anger, rage, guilt, etc. These are emotions that hurt relationships, ourselves, and societies, and they tend to be reinforcing. So people tend to get stuck in them over and over and over again, and then they don't know how to get out. There are some emotions in the red zone that feel a little bit better than others. Like someone could argue that anger or rage and blame feels better than powerlessness and hopelessness and depression. But still, none of them feel good, and you're not actually getting beyond the negative emotions. So fear tends to bring more fear. It creates patterns. We start to live in fear, and anger creates more anger. This helps to create neural pathways that reinforce this, and it's like you go farther and farther down the rabbit hole. For week 1, the activities and topics I've listed below. So there is the 1-hour Zoom meeting, and then there is 7 days of self-reflection for trap patterns and loops, and there's specific activities for that. And there is a compassion-based insight activity that you do over the 7 days of week 1, and it's to help bring awareness to the patterns and loops you're in. And then to listen to at least 2 of the hypnotherapies that are provided out of the 21. Okay, so week 2 is the next week. And with that one, we are looking at identity structure. And again, I have not come across other programs that work with this, even though it is so key. The way that we see ourselves, the beliefs we have about ourselves and the world can poison or uplift your life and those around you. And the thing is that it can be changed. I teach personality for University of South Florida. And, to some extent, some things seem to be inherent to us, but there's a lot of things that we can actually change or question or alter just based off of our awareness. So understanding your own self-perception is directly related to creating awareness and stopping attachment, engagement, and participation in harmful cycles. So as I said, when you measure something, when you notice, it helps you to break out of cycles. It can be hard to see yourself because you are yourself. We get stuck in things. So a big part of unhappiness is not really knowing who we are and trying to be someone we are not, or living a life that does not authentically suit us. There's a lot of research to back this up, but trying to be who you think you're supposed to be, and if it doesn't align with who you are, is very tricky. So, who are you? That is another question, but the first step to understanding who you are is to develop some detachment and notice every day the patterns you have and beliefs, and do they feel good to you or not good? As a general rule, I'd say things that feel lighter and good and are easy for you and probably more close to who you are, and stuff that is more challenging and painful and more of an effort, possibly farther from who you truly are. But that's a huge generality I just made. So yeah, things that feel more natural, look into that. If you don't realize is this happening, and learn to listen to your authentic self, an experience of hopelessness, depression, confusion, powerlessness, and anger can occur. And I see this a lot, that people are not living authentically and they really suffer to the point that I've seen actually pretty bad mental illness and depression. Okay, so during this week, we are looking at the identity circle, and part of it is noticing each day kind of like where you're at in the identity circle. So let's say you've been really upset about your family today for some reason. Okay, well, what pattern, belief, or value has been looping over and over that you've been reacting to? What is it about them that you're reacting to in relation to yourself? So you're identifying where you're getting stuck. I hear a lot from people this belief that they're not where they're supposed to be. They're behind. They're not, where other people are at yet. Well, where did that come from? That belief. Societal or cultural patterns, maybe religious patterns, family. So is that true to you? Is that really true to you? That you're not where you're supposed to be? Or is that based off of what you've been taught? Or you didn't realize you were taught? So this is the identity circle for investigation. The topics and activities for week 2 include a 1-hour meeting and 7 days of identity insight activity, which you're looking at the identity circle. 7 days of self-reflection for trapped patterns and loops. So keeping that going to further support things from week 1, and to listen to at least 2 of the hypnotherapies. Okay, week 3. And this is where it gets even more exciting and interesting, is becoming your own generator. So when you're your own generator, you're seeing the beauty and good in the everyday mindfulness. You're something like taking 15 minutes to notice, experience something positive in the blue zone, and knowing that things are pointers to the experience and not the experience itself. Becoming your own generator is a way of triggering and supporting positive, uplifting emotions you're trying or wanting to attain. So, for example, let's say you're wanting to be more blue zone emotion of appreciation, peace, and calm. So you find, okay, if I see a beautiful tree or park, that seems to help support that. If you're wanting to feel more love, okay, when do I feel more love? Maybe when you're with your dog or pet. Okay, so spending some time with your pet. That's not to say you're relying on them. You're helping to use
the quality of this,
what you already have with that dynamic, to cultivate things, but you're being intentional about it. And eventually you can get to the point that the more you practice, the more you can get to a state of appreciation on your own, or love on your own. Like, for example, I had a client yesterday that was telling me she doesn't feel happy. She's never felt happy. And so we just talked about 2 things or people that she loves. She loves her mom a lot and her dog. And we were just talking about how much she loves them. And magically, even though they were not there in the room, she started feeling appreciation, love, and some happiness. And she started feeling a lot better. And that was just in her mind. So by focusing our attention on things that help stimulate blue zone emotions, we stimulate more and more blue zone emotions. So these things help support that. But the thing is, it's not actually the tree or the park, or you could say your mom or your dog, that is giving you those feelings. You are experiencing these feelings. These are coming from you. You're the generator of that emotion. If you see a tree and you're feeling some sense of appreciation or awe or peace, did the tree do that to you, or did you do that? Did that come from you? That came from you. It's just that the tree inspired that from you. So becoming more and more aware of the things that you're generating. And by the way, you can also generate a lot of negative emotions as well. It's kind of like saying, you made me feel this way. It's like, well, did that person make you feel that way? Or did they inspire the generation of a certain feeling from you? No, it's different. It's sort of taking back, like I said, the self-responsibility, our own agency, so we don't feel as much like victims and we feel more empowered. So it's kind of like ordering from a menu. It's possible to learn how to increase the experience of certain emotions. So you can find things that help to trigger the wanted emotions and work to cultivate and nurture them. You can give the thing you're wanting to experience to generate the experience yourself. What I mean by that is, okay, something I come across a lot is people not feeling like they were loved by their mom or having issues with their moms. Okay, well, you can obsessively focus on that and be suffering a lot and attached to the old negative patterns, or you can try to create some sort of nurturing, loving energy on your own. So I've seen people do this with pets, volunteering at animal shelters, volunteering with children. You can, so like, let's say you wanted to feel nurtured and cared for and validated and seen as a child and you weren't. Well, can you give that to other children? And by doing that, it's not that you're trying to fix yourself through that, but you're giving yourself, you're creating the energy inside of yourself and it comes out from you to others. So it's generated inside of you and flows out from you. So you can also reflect on past healthy ways you improved your happiness and well-being and see, okay, how can I replicate that? So instead of, it's sort of this intentional cultivation of the emotion that you're wanting. Okay, and the topics and activities include the 1-hour Zoom meeting, the 7 days of identity insight activity, 7 days of self-reflection for trapped patterns and loops, and listening to at least 2 of the provided hypnotherapies. So for this, there's a 3-day generator activity. And for 3 days, you take 15 minutes out and you try to intentionally cultivate a certain emotion that you'd like to experience. Okay. Week 4, turning pain into strength. So one of the traps that can happen with red zone emotions is not even realizing you're experiencing them and are stuck in repetitive patterns and reactivity. So suffering happens to everyone at some point and in different forms, but it's possible to turn trauma, pain, and red zone emotions into something that benefits yourself and others when seen from different vantage points. So turning our painful emotions into positive, it doesn't invalidate the destructive, but it's rather saying that you want to have more power over your life and that you love yourself enough that you don't want to suffer. You want to feel better. So the topics and activities for week 4, there is 7 days of the self-reflection and readings, and then the Zoom meeting, hypnotherapies, and there's the transformation activity. The transformation activity is 3 days of transformation. And here are the instructions for day 1, day 2, day 3. So the first is reflecting on the term radical allowance. Another one is looking at a negative emotion you've been struggling with and trying to do a letter or an audio note, thanking it for what it's done. If you're wondering why I'm saying this, it is because when you do this, you're doing 2 things. You are validating and acknowledging it. You're demonstrating some self-awareness and appreciation and gratitude. And these are all blue zone emotions to pull you out of red zone emotions. Day 3 is reflect on 3 things in your life that have upset you or you felt were negative or harmful. And try to reflect on positive or potential positive that can come from each bad thing. So trying to understand, okay, how can something good come from this? And again, it's not to invalidate it. It's to help you move forward with it. Move forward in your life. Okay, so week 5, taking responsibility for your happiness. So one of the great challenges is the transition here from being in the red zone to blue zone. The red zone, you can have a lot of victim feelings and that you have no power or control. And this is not to say you haven't been through things. It's really not. It's to say that Okay, you love yourself enough that you don't want this to be the rest of your life. You love yourself enough that you want to feel good in spite of anything that's happened because you love yourself and you want to feel better. And this is an act of self-kindness, self-love, and compassion. Also, when we're not in a good space, it does affect others around us. And so it's also a kind thing for others. When we are happier, we help other people because we're all interconnected. So by taking more individual agency, empowerment, and accountability for our happiness, it means partly that we are committing to an internal state of feeling better, regardless of challenging outside circumstances. Some people say, does that mean you're deciding to be happy and that happiness is a decision? Well, yes and no. I see it as more like a commitment and a priority that, okay, today I am making a commitment and a priority to feel good. I'm making happiness a commitment. I kind of think that might be a better way of looking at it. Because it does take some effort, especially at first when you're getting from red zone, when you're getting out of the red zone to green and blue zone, it does take work. Eventually becomes more and more easy, becomes your new norm, and you feel better and better. It becomes more natural, but it is a commitment. It's a discipline, I'd say. Okay, so some topics for week 5 include, again, the 1-hour Zoom meeting, the 7-day happiness challenge, the 7 days of self-reflection on happiness, 7 days of simplification, and the hypnotherapies. If you're wondering why I keep saying 7 days, 7 days, 7 days, is because it's a daily activity that is for week 5. And there are different components that will help with increasing happiness. So the happiness challenge, here are the prompts for it. And this involves some, you can do audio notes or writing, but it has to be something tangible. And it's a challenge because this is shifting the mindset towards the commitment, discipline, priority perspective regarding happiness. So, I mean, we have to learn pretty much everything, and we have to work at pretty much everything. Why in the world would happiness be different? And people might think, well, but okay, I'll be happy if I get this job, if I have this, if I have that. Yes, maybe, but usually it's temporary, and it's a little disempowering because you're relying on that outside thing and attaining it and maintaining it. But what if you can find how today you can start to cultivate more happiness and learn how to be aware and happy regardless of what's going on? And I'm not saying you're going to always be like flying high and fantastic, but I mean content and feeling empowered and feeling good. And of course, there's various degrees of up and down, but you can get to the point where you feel good pretty much all the time. Okay. And of course, there's caveats to what I just said because I'm making generalizations, but I'm trying to point out there's an empowering way of going about this, that you create your happiness versus having to consume and take from the outside. Okay. The last week is living and loving intentionally. And this talks about the importance of having our lives with purpose and intentionality, and not living in a reactionary way, but in a way where we're deciding how I want to experience. You're deciding every day, I want to be in the blue zone, or I want to be feeling this in the green zone. You are choosing. It's not choosing you and taking over. And then also, though, this week focuses on the importance of kindness towards yourself and others, and that there is value in being happy, feeling hopeful, and inspired. It helps you, but it also helps others. And increasing and maintaining conscious kindness is a key part of happiness and mindful living. So part of this is we generally feel good if we are doing something positive for others. We're not just focusing on ourselves. And that's sort of a good shortcut, actually, if you want to try it out for happiness. I don't mean obsessively and only focus on others. There has to be a balance of both yourself and others. But a lot of people, everybody suffers. Everyone has suffering and challenges. And so you never know how your kindness can spark other kindness in others. And that is empowering. Okay, so topics and activities for week 6. There is the 7 days of kindness activity, 7 days of self-reflection for living and loving intentionally, increasing your inspiration activity, hypnotherapies, and the Zoom meeting. This below is the inspiration activity. It's 7 days of writing or audio notes, of focusing on things that help to inspire and uplift you. Here is the 7 days of kindness. Essentially, it's intentionally doing one act of kindness for yourself or someone else today. Because again, when you feel good, it does flow over and affect others in a positive way. So when you feel good, you're also helping others. It's contagious. When you feel miserable, it's also hurting others. Our emotions affect each other. So day 1 has a particular prompt about thinking about a cause or situation you care about in your community, country, or world. And then there's another one about looking at these phrases and, reflecting on one that feels important to you. And then there is each day for days 2 through 7, intentionally doing one act of kindness for yourself or someone else that day. Okay. So sustainability after the 6 weeks and beyond. So this is good. It provides a good foundation of practices, but how do we keep it going? And I wanted to create something that is going to be powerful, but easy and you can keep doing it. So I created the zones of self-love chart and also daily self-value ratings. So what I would encourage everybody to do after completion of the 6 weeks is check in with themselves every day. Okay, are they purple zone, loving themselves unconditionally or loving themselves? Are they blue zone, liking, neutral, or don't like? Are they orange zone, hating themselves? Are they yellow zone? They don't even know what this means. The first step truly is the yellow zone and knowing what I'm talking about. Something I see over and over is people don't know. If you ask them, do you love yourself? They don't even know what that means. If I ask, do you like yourself? Do you hate yourself? Usually there's a better idea about the hating yourself, but even still, sometimes, quite often, I find that people, they don't know what it means. They're stuck in these unconscious patterns and reactions. And one way to, as I said, when you measure, you improve. So one way to get to the place of loving yourself unconditionally is checking in every day. Am I purple zone, blue zone, orange zone, or yellow zone today? Okay, so why does this matter? This matters because what I have found is one of the greatest challenges with happiness and mindfulness is people hating themselves, or having mixed feelings about themselves, or having no idea how they feel. When you love yourself unconditionally, it is very powerful. It means you accept yourself, you're at peace with yourself, and this affect, and you're able to live authentically, and this affects others around you, and it's very empowering. And you treat others differently, because when you don't like yourself or you hate yourself, you have mixed feelings or you don't know, there tends to be more shame cycles, more depression, more unhappiness. And so loving yourself unconditionally, and I know that can be confusing for people. So essentially accepting yourself and being at peace and harmony with yourself is really key to be mindful and happy. And so again, rating every day. Am I purple, blue, orange, or yellow zone? Takes 30 seconds. And then the second thing for sustainability is checking in with yourself from 1 to 10. How valuable am I? 1 to 10. You could say it's a trick question because, you know, as I say to clients a lot of times, the biggest thing I do come across over and over is people having issues with self-worth and not being happy with themselves, or not knowing what it means to love yourself. So what I say to people a lot of times is, okay, does a puppy or a baby, how valuable are they? They're not doing very much. You know, everyone always says, oh, they're so valuable, you know, 10 out of 10. I'm like, well, what's the difference between you and the baby? You're actually doing way more than a baby. They're like, yeah, but there's more expectations. I'm like, okay, but you didn't lose your value and worth just because you got older. Your value is inherent. And this is a big part as well of mindfulness and happiness, is feeling that you have inherent value and worth, no matter what you've done, good or bad, you know, painful or not painful, positive or negative, whatever, you have value and worth. And the irony is, when you feel like you have more value and worth, you're better able to look at things that you've done that aren't great. You're better able to have courage to make changes. You're better able to get out of the victim zone when you love yourself unconditionally and you feel you're valuable. And just by rating this, it will naturally improve itself. Okay, so lastly, the teacher training. So to be trained in this, do an initial training meeting. So do the whole program. Complete the happiness-based mindfulness program over 6 sessions in total. And there's required materials as well to read through to understand concept of things like radical acceptance, allowance, happiness and mindfulness, reframing negative beliefs and thoughts, mindfulness in everyday life. So basically you would be doing the program yourself, and then having a deeper understanding of how it's done and a deeper understanding of the concepts. Okay, so some takeaways of this psychoeducation program. Happiness can be taught. It can be learned. And there are tangible tools to teach and learn to increase happiness. The tools are simple, straightforward, and easy to learn on your own and integrate into your life even after the program. And when I say happiness, you're like, what does that mean? Well, like anything, you could think of happiness as a spectrum. Let's say 1 to 10. 10 being really happy and 1 being not very happy. Okay, are you at like a 2 right now? Well, maybe this program can help you get to a 4 or 5 out of 10. Maybe it can help you get to an 8 out of 10. I don't know, but you can improve happiness. So the goals of this program are to increase happiness levels of every participant to some degree, like I said, on the spectrum, to teach participants new tools to improve their life, and to teach a new type of psychoeducation that goes beyond current ways of understanding our psychology and well-being and creates breakthroughs for every participant that fully completes the 6 weeks of curriculum. I really want to see breakthroughs for everybody that does this. Okay, thank you so much. I'm so happy that you were here to listen to this. And if you want to reach out to me, I can be reached at www.drsarahspowert.com or by email at sarah.spowert@gmail.com. All right, thank you so much.